the COVID-19 pandemic 1 year later. Without objection, the chair is authorized to declare the committee in recess at any point. The gentlelady from Florida, Ms. Dimmons, shall assume the duties of the chair in the event that I run into technical difficulties. With that, I recognize myself for an opening statement. Almost 1 year ago, on March 4th, 2020, the Committee on Homeland Security held the first congressional hearing to examine the novel coronavirus that had begun spreading around the world. A week later, on March 11th, 2020, the World Health Organization declared COVID-19 a global pandemic. Since then, over 500,000 Americans have died from the virus, a tragic, catastrophic loss of life. In remembrance of those who've lost their lives to COVID-19, I ask the committee to observe a moment of silence. Thank you. The committee is meeting today to examine perspectives on the COVID-19 pandemic 1 year later. We are fortunate to be joined today by witnesses representing two of the same organizations that came before the committee at our March 2020 hearing, and I look forward to resuming our discussion. Examining the failures in the federal responses so far and applying lessons learned is essential to ending the pandemic and keeping Americans safe. Unfortunately, President Trump ignored intelligence on COVID-19, made states compete for PPE and testing supplies, rejected science on masking and distancing, silenced medical and scientific experts in his own administration, and failed to develop comprehensive plans for testing and vaccine distribution. The American people have paid dearly for those failures and continue to do so today, in some cases with their lives. Late last month, the Government Accountability Office released a scathing report on the Trump administration's persistent failure to address critical problems in the COVID-19 response. Nearly 90% of GAO's recommendations remain unimplemented as President Trump left office, leaving the normally reserved government watchdog agency deeply troubled. Among the most significant failures identified was the lack of a comprehensive plan for COVID vaccine distribution. According to GAO, without a plan, each state was left to create its own plan for locally distributing the shots and launching programs for getting them into people's arms. We all know how that's gone. I doubt to say that every member on this committee has received calls from constituents asking how and when can I get a shot. Long waits for appointments at under-resourced local public health departments, older people trying to navigate a patchwork of overwhelmed private pharmacy websites to get a shot, and minority and underserved communities being left behind despite suffering disproportionate illness and death from the virus. This is the situation the Biden administration was handed by its predecessor. President Biden is taking aggressive action to try to rectify these failures and bring the pandemic under control. But it will not be an easy task. Executing the national strategy for the COVID-19 response and pandemic preparedness will take a coordinated effort along federal, state, local, tribal, and territorial governments and private sector partners. I hope to hear from our witnesses today how Congress can be helpful in that endeavor. Getting the pandemic under control will also take addressing the disproportionate toll COVID-19 has taken on minority and underserved communities. The risk of dying from COVID is nearly 7 times higher in Hispanics and 5.5 times higher in African Americans than others. Yet minority and underserved communities are having trouble accessing life-saving COVID vaccines. In my state of Mississippi, only 20% of the vaccines have gone to African Americans, even though African Americans comprise 38% of the state's population. In one Mississippi county, less than 9% of vaccines have gone to African Americans, even though 26% of residents are African American. President Biden's executive order and task force on COVID-19 health equity are a good start, but more needs to be done to ensure equitable vaccine access and outcomes. I was heartened to hear of the creation of a civil rights advisory group within FEMA that will be working on this issue, and Americans can be assured this committee will be conducting close oversight of their work and supporting their efforts. The federal government is paying for these vaccines with taxpayers' money, and it must ensure that all Americans have equitable access to them. I thank the witnesses for joining us and members for their participation and look forward to a robust discussion. With that, I recognize the ranking member, the gentleman from New York, Mr. Katko, for an opening statement. You might have to unmute yourself.
You had to unmute me. Thank you, Mr. Chairman. I appreciate it. Thank you for your comments. Thank you for holding this necessary hearing today as well. I appreciate your tackling this topic so early in the Congress. The mere fact that this hearing is being held virtually demonstrates the degree to which the COVID-19 pandemic has interrupted our daily lives. Like very few things during my lifetime, the COVID-19 pandemic has impacted every American in some way. It has had a crippling effect on our economy, forcing small businesses to shutter their doors. It has threatened the financial stability of millions of families, and it has taken a significant toll on the mental health of countless Americans, including our school children. We need to do everything we can to support those suffering, including by taking appropriate steps to get our kids back in the classroom as quickly and as safely as possible. Not to mention the horrific number of deaths that have occurred. I saw media reports just last week that life expectancy in the United States fell by a full year in the first 6 months of 2020, resulting from the pandemic, with racial minorities, as you noted, suffering even greater declines. This is the largest drop since World War II, and it's absolutely tragic. My thoughts and prayers go out to everyone who has suffered through this pandemic, especially those who have lost loved ones. Sadly, a year later, when many of us thought we would have returned to a semblance of normalcy, we are still deep in the throes of this pandemic. Although it is a positive sign that cases and deaths may be trending down, at the moment, the numbers are still way too high. Many have become numb to the news on any given day in the United States that thousands more of our fellow Americans have lost their lives to this devastating virus. Just last week alone, we lost more than 10,000 Americans to COVID, and in the last few days surpassed 500,000 deaths totally. Luckily, the vaccines have given us some much needed hope, but we are still a long way from the end. We need to do absolutely everything we can to get as many Americans vaccinated as quickly as possible. Most of the news in 2020 surrounding the pandemic was awful, but I would be remiss without mentioning that we saw innumerable feats of courage and perseverance. As we know, Mr. Chairman, the American people under the most horrendous conditions throughout history have always stepped up to defy the odds. Throughout the 2020 year and continuing to this day, we see tremendous courage from healthcare workers and first responders on the front lines who continue to put their lives on the line to help their fellow Americans, and I commend them for that. Although the media tends to focus on the larger cities where the cases are higher, I would like to use this opportunity to highlight that the pandemic is everywhere, in districts like yours in Mississippi, Mr. Chairman, and mine in Central New York. And I would argue that the pandemic has had an even equal or even larger impact on our smaller cities and more rural communities. I want to urge all those working on the response to the pandemic not to forget about the impact this deadly virus is having on communities in my districts such as Syracuse, New York, Auburn, New York, and Oswego, New York, and many, many others. In Central New York, we have seen the pandemic contribute to rising rates of mental illness, substance use disorders, and a nearly doubling of overdose deaths for heroin. My witness today will highlight some of those challenges. In my congressional district, we have seen north of 45,000 COVID cases and more than 800 deaths. Even though the country has been given a ray of hope with the vaccine, there is much left to do, including, and I hate to say it, and I hope it never happens, plan for the next pandemic. Now that we know firsthand that something like this is possible, we need to compile lessons learned and best practices to ensure we build an effective and aggressive strategy to respond to public health crises of this magnitude. Pandemic preparedness is a critical part of the Homeland Security mission. We must ensure that federal, state, local, and tribal governments have diligent plans in place for a public health response to this and future pandemics. Longer term, we need to engage in a study of our medical and pandemic response supply chains to identify where we are overly beholden to foreign nation states, like China, that don't share our interests. I believe the department can play a critical role in this work, and Mr. Chairman, I see great opportunity, as always, for bipartisan collaboration. We always accomplish the most when we work collaboratively across the aisle to address the needs of the American public. Again, Mr. Chairman, thank you for holding this most important hearing today. I look forward to the testimony of our witnesses, and with that, I yield back, my friend.
Other members of the committee are reminded that under committee rules, opening statements may be submitted for the record. Members are also reminded that the committee will operate according to the guidelines laid out by the chairman and ranking member in our February 3rd colloquy regarding remote procedures. I now welcome our witnesses. Ms. A. Nicole Flowers serves as the managing director of the healthcare team at the Government Accountability Office. She's been with GAO since 1998 and is one of the people leading GAO's reporting on the federal government's COVID-19 response. Dr. Crystal Watson is a senior associate at Johns Hopkins Center for Health Security and assistant professor in the Department of Environmental Health and Engineering. Her policy research focuses on public health risk assessment, crisis and risk-based decision-making regarding preparedness and response, biodefense, and emerging infectious diseases. Dr. Ignawi Iwike is the director of the Illinois Department of Public Health. She's a board-certified internist and pediatrician, and the testimony she provided to the committee 1 year ago was invaluable to our understanding of a difficult road ahead. I thank her for agreeing to return today. I now like to recognize the ranking member for the purposes of introducing our fourth witness.
Thank you, Mr. Chairman. And my witness's name is a little bit easier. His name is Ryan McMahon. Good argument from Syracuse. And I'm proud to introduce a constituent of mine, Mr. Ryan McMahon. Ryan is an Onondaga County executive and has been so since 2018. He started his career in public service as a Syracuse City Councilor in 2005 after being elected at the ripe old age of 25. He was reelected in 2007 for a second term and quickly distinguished himself as a bipartisan problem solver. In 2011, County Executive McMahon was elected to the 15th District of the County Legislature of Onondaga, which includes portions of the city of Syracuse, the town of Geddes, and the town of Onondaga. Ryan was subsequently elected chairman of the county ledge in 2012 by his fellow legislators, becoming the youngest chairman in county history. Upon taking office as county executive, Ryan McMahon has placed a focus on three main initiatives: poverty, infrastructure, and economic development. And obviously, Mr. Chairman, Ryan's main focus now is COVID. He has done a remarkable job leading us through this pandemic in Central New York and has held daily briefings that have been superb. And I commend him for his leadership in that regard. I've enjoyed working with Mr. McMahon during my life in the House, and I'm thrilled that he's able to testify with us today. And with that, Mr. Chairman, I yield back.
Thank you. Without objection, the witness's full statement will be inserted in the record. I now ask Ms. Flowers to summarize her statement for 5 minutes.
Thank you, Chairman Thompson, Ranking Member Katko, and members of the committee. Thank you for the opportunity to discuss the federal government's ongoing response to COVID-19. Through the CARES Act, Congress directed GAO to provide ongoing real-time oversight of the federal government's response to the pandemic. As of January, we have issued 5 reports containing 44 recommendations. About a third of those recommendations were directed in the following public health areas: COVID testing, vaccine distribution, medical supply chain, COVID health disparities, and COVID data. My written statement details each of those recommendations. We believe each, if fully implemented, would improve the ongoing federal response. In my comments this morning, I'd like to focus on 3 of those areas: vaccine distribution, the medical supply chain, and COVID disparities. First, the topic that's on everyone's mind, vaccine distribution. As you know, as of today, 2 vaccines have been authorized for emergency use and are being distributed. The emergency use authorization request for a 3rd vaccine candidate is pending before the FDA. The rapid development of these vaccines is an achievement. But as we and others have reported, the distribution of the vaccines had not met expectations through January. And while the distribution pace has recently increased, challenges continue to be reported. Distribution of authorized vaccines across the nation is a daunting, complicated logistical endeavor, in part because of the number of entities involved across all levels of the government and the private and nonprofit sectors. This is why we recommended in September 2020 that HHS, as part of a national plan for distributing and administering the vaccine, outline an approach for how efforts would be coordinated across federal and non-federal partners. To date, this recommendation has not been fully implemented, and we maintain doing so, especially ensuring local officials are part of the planning efforts, would improve the nation's distribution efforts. The second topic that I'd like to highlight is the medical supply chain. The pandemic has highlighted vulnerabilities in the nation's medical supply chain, which includes personal protective equipment and other supplies necessary to treat individuals with COVID and to vaccinate people. Providing medical supplies to meet the continuing needs has been a persistent challenge. We have made multiple recommendations to improve the federal government's management of the medical supply chain. For example, we recommended that HHS should develop plans outlining specific actions the federal government would take to mitigate medical supply gaps for the duration of the pandemic. We also recommended that HHS work with federal and non-federal stakeholders to help states enhance their ability to track the status of supply requests. Implementing both of these recommendations would help address the supply challenges. Finally, I want to highlight the healthcare disparities related to COVID-19. Available data from CDC and others show communities of color bear a disproportional burden of COVID-19, to include cases, hospitalizations, and deaths. For example, available data show that the rate of COVID-19 hospitalizations for Native Americans is almost 4 times the rate for white Americans. While CDC collects race and ethnicity data on indicators of COVID-19, we found gaps in the data. For example, data on race and ethnicity for COVID-19 vaccine recipients were missing for almost half of the recipients who received at least 1 dose. The lack of complete race and ethnicity data hinders the government's ability to take corrective actions. In conclusion, over the past 2 weeks, case counts and deaths have thankfully slowed since peaking in January. But public health officials caution that we should not become complacent in our efforts as new variants emerge. Until the country better contains the spread of the virus, the pandemic will continue to lay bare the fragmented nature of the public health sector, the fragility of the medical supply chain, and long-standing disparities in healthcare access, treatment, and outcomes. Chairman Thompson, Ranking Member Katko, and members of the committee, this concludes my prepared statement. I would be happy to answer questions at the appropriate time. Thank you.
Thank you very much. I now ask Dr. Watson to summarize her statement for 5 minutes.
Chairman Thompson, Ranking Member Katko, and members of the committee, thank you very much for the opportunity to testify to you today. 1 year ago, the director of our center, Dr. Tom Inglesby, testified to this committee about the grave threat of COVID-19 and the need for a robust response. There was significant uncertainty at that time about how the pandemic would play out. Today, we have answers to many of the early unknowns and are now vaccinating millions of Americans per day. But on balance, our national response has not met its potential, and many thousands of deaths have occurred unnecessarily as a result. As has been said, we've just reached a terrible total of 500,000 deaths nationwide. More Americans have now died from COVID-19 than in all 20th century wars combined. And despite having only 4% of the world's population, our country has contributed 25% of the global total of cases and 21% of reported deaths. And these are just the officially reported statistics. The true burden of COVID-19 is unknown, but is estimated to be much higher than what is recorded. As has been stated already, the consequences of the pandemic have been appallingly unequal. When adjusted for age, people of color and Indigenous people have been over twice as likely to die from COVID. Yet, while the last year has been a nightmare, there are now some glimmers of hope. The number of US cases, hospitalizations, and deaths are all dropping rapidly from the winter peak. I expect that this trend will continue due to a combination of mitigation measures and vaccination. While the vaccine rollout has been anything but smooth, it is improving. The emergence of consequential SARS-CoV variants of concern is troubling, but I'm hopeful that vaccination and current mitigation measures will prevent a severe resurgence in the US this spring. However, it's something that we obviously have to watch very closely. Vaccination is the centerpiece of the current US response, but it's also important to note that low and middle income countries are mostly still waiting for vaccine. This is a humanitarian crisis for those countries, and it also represents a significant risk for the world because it could prolong the pandemic. Now, I'd like to take a few moments to briefly highlight some of the successes and failures of the US response over the last year. First, the successes. It's so important to recognize that the response represents collective work from tens of thousands of people across the country. We should be truly thankful for the heroic efforts of those who have worked to reduce the impact. And of course, the biggest and most visible success over the past year has been the development of multiple highly safe and effective vaccines and therapeutics. I can't emphasize enough what a technical feat this is. Now to the challenges. Over the last year, health officials and experts who've tried to follow the evidence and protect the public's health, including through implementing masking, contact tracing, and business restrictions, have faced harassment and political pressure and have at times been stripped of or resigned their positions. In addition, risk communication has been severely challenging in the face of high-level denial of the severity of the pandemic and overt politicization of public health measures intended to keep people safe. These failings have allowed the virus to flourish. Historically, our public health agencies have not been sufficiently resourced to respond to a crisis of this magnitude. As just one example, during this response, only $200 million was provided to states to support distribution and administration of vaccine during the largest mass vaccination campaign in our nation's history. Support for our healthcare response has been similarly dismal. States often had to go it alone when procuring important things like ventilators, testing supplies, and PPE for frontline health workers. Finally, the withdrawal from the WHO and withholding of contributions from COVAX both weakened our position as a global health security leader and limited global vaccination efforts. With the new administration and Congress in place, I'm hopeful that our response to the rest of the pandemic will be much more evidence-based, coordinated, and effective. The American Rescue Plan currently being considered by Congress would provide significant support for the response, as well as authorization for new programs that will begin our investment in future preparedness. I look forward to the passage of this bill and better days ahead. This concludes my testimony. I'm grateful to the committee for inviting me and would be happy to take questions. Thank you.
Thank you. Thank you very much. I now ask Dr. Ezike to summarize her statement for 5 minutes. And I apologize if I mispronounced the word. Charge it to my head, not my heart.
No problem, sir. Thank you. Chairman Thompson, Ranking Member Katko, and distinguished members of the committee. Thank you for inviting me here to speak today about Illinois' response to the coronavirus pandemic. We've had more than 1.1 million cases of COVID-19 in Illinois, and even more deplorable, over 20,000 parents, grandparents, and children who have succumbed to this baleful disease. From the outset of the pandemic, our response has been guided by a focus on data, science, and equity. 2020 mitigations necessary to curb infection transmission and protect healthcare capacity still left an indelible mark on the state of Illinois and the lives of our residents. As a state, we've made significant investments in testing and contact tracing. Our state lab was the first in the country to validate and run in-house the CDC's PCR test, and we are proud to rank 5th among states for a total number of COVID tests run. As vaccines are distributed, the benefits of vaccination will depend on, one, how rapidly and broadly we can turn vaccine into vaccination, and two, how effectively we limit viral replication, thus limiting the creation of new variants of concern. In Illinois, more than 2.3 million doses have been administered. Currently, we have administered 90% of all delivered doses outside of the long-term care pharmacy partnership program. We currently rank 5th among states in total vaccines administered. The Department of Public Health has been intentional about engaging disproportionately impacted communities. From the beginning of our response, we created a health equity work group that was embedded into all aspects of the response. We assembled a diverse speakers bureau to support multilingual virtual town halls for cultural groups, work groups, faith communities, and other special groups. Our ambassador program enlists nearly 1,000 Illinois residents to share information via personal social media channels to their friends and family and peers on prevention, testing locations, treatments, and vaccine. We aim to create confidence and trust in the available vaccines through education and culturally appropriate, respectful engagement. Our hope is that when people get the facts, then they'll get the vax. When I testified before this committee a year ago, one of our primary concerns was the lack of PPE for healthcare workers and first responders. Today, we are in a much better position as production and demand have equalized. Even so, we learned a very valuable lesson about the global supply of medical products that must inform our future planning for strategic national stockpiles and domestic production. One of the biggest hurdles to a successful response over the past year has been a lack of clear and consistent communication and muddled messaging from the highest levels of government on down. While we appreciate the increased planning, transparency, invocation of the Defense Production Act for vaccine supplies and PPE, and the securing of 600 million doses by July, today, we still have to contend with the good trouble of having more rolled up sleeves than vaccine-filled syringes. We are seeing increases in our vaccine supply and welcoming the strong commitment from the federal government to augment the state's vaccination efforts. The promise of a 3-week lead time on vaccine allocation has been welcome news both to the state and to all of our local partners. Last month, Governor Pritzker announced the activation of the Illinois National Guard to assist local health departments in administering vaccines. To date, 44 teams have been deployed with the plan to reach 100 total Guard teams in the coming weeks. FEMA is another great partner in our efforts, and the 100% federal cost coverage allows us to support additional high priority areas. We have also discussed mass vaccination centers and are hopeful that this federal-state partnership will come to fruition. To bring this pandemic to an end, we need to stay focused on the multi-layered approach of masking, social distancing, testing, genomic sequencing, contact tracing, in addition to vaccination. To maintain all these efforts, states need consistent resources, but also expertise and national guidance. Yes, national strategies have a clear role and function in battling pandemics because state borders do not keep out the virus. And yes, our national strategy has to include control of the virus in other countries, especially developing countries, because as we have also learned, no one is truly safe until all of us are safe. And viruses are only as far away as the furthest flight or the furthest cruise voyage. I look forward to continued collaboration with Congress and the administration to see the other side of this pandemic, where pandemic fatigue, frustration, and fear is replaced with a post-pandemic sigh of relief. Thank you.
Thank you very much. I now ask Mr. McMahon to summarize his statement for 5 minutes.
Thank you, Chairman Thompson, Ranking Member Katko, members of the committee. It's an honor and a privilege to be here today to help tell the story from the local government perspective. And our story isn't unique to our community, but to local governments throughout this pandemic. And the reality is, it's important when we tell this story that people understand what we do. Our county government does different things in each state, and that's been part of the challenge in the global pandemic at the local level. In our county in New York State, and I know there's members from New York State on this panel as well that know this, in New York City is actually a county as well. In New York State, the rest of the counties, we take care of our community's most vulnerable. We have the children and family service departments to watch our children. We have the adult and long-term care departments to take care of our elderly. We have our economic security departments to take care of our poor. And we have our local health departments that help deal with health equity and public health day in and day out. And during a pandemic, everybody is vulnerable. And we were the local government on the front lines of this. And when we look at what we do and what we had to do, reliving the last year and our response is actually a traumatizing experience if we think about all we've been through together collectively in this country. We went from planning when we learned of this virus to preparing to having to do mitigation at the local level, canceling community gatherings, canceling parades before we even had a case. And then we went to response to a pandemic at the local level. In our community, we're in central New York. In New York City, in Long Island, on the Hudson Valley was ground zero for this pandemic. We had a 2-week head start to implement mitigation, implement our plans, and prepare for response. What is response? We got very familiar very quickly with terms like contact tracing, testing for a virus, competing for tests throughout the community. We quarantine. These are all things that we never thought we would have to do at this point in time. We then went into a situation where we were focused in on shutdowns to help mitigate the spread of the virus throughout the state. We then went through a restart process where we started to reopen our economy, where our governments were now responsible for regulating social distancing, physical distancing, capacity amongst businesses, things we never thought we would be. As we restart our economies, the Operation Warp Speed and the vaccination came to fruition. We now are in the process of vaccinating, developing distribution, underutilized infrastructure. How do we get to specific communities within our community that are underserved intentionally? And that's something that we have focused on in Onondaga County. And we'll be the frontline leaders in recovery as well. One thing I do really want to highlight is that once we're done vaccinating, and we will at some point, this emergency is not over whatsoever. The reality is the victims of this pandemic are far more than just those who become COVID positive. We've had 31,000 COVID positive residents in my county. We've had over 650 people in my county die. But it is becoming clearer and clearer every day, the crises of mental health, opiate overdoses, where we've seen increases between 40 to potentially 70% in our county. Where we're seeing what's happening to our children as hybrid learning schedules are not there, meeting the needs of our children for school. But this is the macro level. What are some of the unique experiences that we had that I think bring value to you as you form policy? In the beginning, we were not prepared for PPE. We were scrambling for test kits, Every night we were looking for test kits throughout our community to get people just tested for this virus on March 16th when the virus came to our community. We were scrambling for masks, for gowns, for gloves with all of our partners. We were competing not only against other local governments and hospitals, but states and the federal government as well. It is abundantly clear that there needs to be a supply chain repatriation to our country to address this moving forward. We communicated daily at the local level as others did at the federal level and state level. That helped provide comfort and calm to our community, but we had new challenges. Everyone was vulnerable. We had to implement continuity of food operations. We had to implement continuity of care operations for our essential workers where they had free daycare. Things that were never in the traditional response to an emergency, but now local governments were fronting these costs to make sure that we had nurses going into hospitals, to make sure that we had other essential workers going on. So society moved on. We did this all at a point where we were the largest community in the country to receive no direct CARES Act support. CARES Act funding flowed through the states. There was money earmarked for local governments. Not all states passed the money onto the local governments. This led to a huge economic challenge for us in Onondaga County, a community of 462,000 people that would have normally received $80+ million if we had over 500,000 people. We received no direct CARES Act funding for response because of the way that the emergency aid flowed. We quickly utilized and worked with our partners at Upstate Hospital, Syracuse University to implement great testing strategies. We implemented these testing strategies to help restart both pre-K through 12 education, but also higher education. We continue to asymptomatically test in our schools, and the rates of positive rates are phenomenal because of this. We took the strategy that we should not be embarrassed to identify the virus anywhere, because the only way we get our arms around this virus and end this pandemic is to identify it everywhere. And we test and we test and we test today. And because of that, our positive rate in our community today, after a surge from Halloween through Christmas, is at 1% for a 7-day average. Our active caseload on January 3rd was 6,000 cases. Today it's 660 cases. We're now in the process of vaccinating. And vaccinating is something that counties do. The federal government funds us to actually put together mass vaccination plans. We put together these plans. We are ready for this process. To date, we feel we've been underutilized. The supply we know is an issue, and we know it's getting better. But specifically to intentionally get to the hard to reach communities, our new American communities, our minority communities, nobody is better served to do that than county governments. We have the human service partners. These are our clients day in and day out. We can get the job done. We need to be brought into the game in a larger aspect. Thank you, Mr. Chairman, and I'm prepared to take questions when appropriate.
Thank you very much. I thank the witness for his testimony. I remind each member that he or she will have 5 minutes to question the witnesses. I'll now recognize myself for questions. Dr. Ezike, a year later in this pandemic, what more can the federal government do to help states like Illinois deliver vital medical care to those hospitalized by the virus and support state vaccination efforts?
Thank you for that question. So there is a plethora of needs that can be coordinated at the federal level. Of course, as I mentioned in comments, we need federal strategies that helps unify the efforts of the states, which in turn unifies the efforts at the local level. We know that in terms of the variant, we need a very organized system of surveillance to identify ahead of time variants, mutations as they come on board. We need to be able to collect all the different variants that are identified throughout the states in a very robust library to be able to track that. We need data, we need a comprehensive data technology upgrade such that we can have our systems, our state registries, give the important information to the federal government so that we can see exactly what's happening across the country. We know that people live and work in different states, and so being able to have more seamless connection between our partners is also necessary. But the technology solutions are one of our biggest needs, the technology solutions to make sure that we can collate all this important information.
Thank you very much. Dr. Watson, based on your research, can you explain how America ended up with the highest number of COVID-19 cases and deaths in the world, and what should have been done differently, and what must be done now to overcome these mistakes?
Thank you for the question, Chairman. I think it's obviously a combination of factors, but I do think high-level communication about the pandemic was very muddled. Sometimes it undermined the advice of public health experts, and it did not help people to take the protective actions that they needed to take to keep themselves safe from becoming infected. And so we have really seen this virus thrive in that type of a communication environment. We've also seen that support for public health agencies has not been enough. They have not had the resources they need to do testing at a level needed it, to help people to stay home when they've been infected or have been exposed to the virus, to do contact tracing at a high enough level to keep up with cases and contacts. All of these things must improve. We're seeing more direct and clear communication with the public now, but that must continue, and we need to be able to backfill health departments who have been going into the red to try and conduct this response. Obviously, that is also needed for vaccination efforts, which are still undersupported and need to ramp up over the next months.
Thank you very much. I'd like to hear from Mr. McMahon. As you know, FEMA is paying for 100% reimbursement for the cost associated with this pandemic. Are you current in your reimbursements request, or kind of explain how that process is working for local government?
Thank you, Mr. Chairman, for the question. Recently, we were approved for our FEMA reimbursement for 75%. Since the President Biden, I believe, whether it was an executive order, he's pushed us to potentially be eligible for 100% reimbursement for our expenses that were spent in 2020. I think one of the challenges, if you think about the way we budget in local government, in 2020, we never budgeted for COVID-19 pandemic response. We then had economic shutdowns. In New York State, for local governments, our largest driver of revenue is sales tax. So when our economies were shut down, we lost up to 40% of sales tax for that period of time. So we never budgeted for these expenses to begin with, so there was never revenue behind it. We then lost the flexible revenue and had to make cuts, mid-year cuts to our budgets. So even though now we may be receiving some response from FEMA at this point, the model is challenging in the middle of a pandemic to cash flow basic expenses. Governments had to borrow at times to cover expenses due to this the model of reimbursement. So certainly something that should be considered moving forward.
Thank you very much. Chair, I recognize the ranking member of the full committee, the gentleman from New York, Mr. Katko, for questions.
Thank you, Mr. Chairman, and thank you all the witnesses for the testimony. This is obviously vitally important to getting an understanding of what we can do better. County Executive McMahon, we've had many conversations over the past year and many meetings over the past year about some of the things you touched upon in your testimony, which I would like to highlight. The overarching observation from me from all those conversations and meetings is that there's a question of equitable distribution of supplies, equitable distribution of vaccines, and equitable distribution of funding that we provided. And you've highlighted a little bit about the CARES Act funding that went to New York State, but since you were just under the threshold of 500,000, you didn't get the funding directly like your neighbor to the west of you did, Rochester, and that had a dramatically negative impact on your budget. So you've touched on that, but I want to talk about FEMA's role in this equitable distribution. It seems to me that FEMA is somewhat hamstrung in their ability to equitably distribute the vaccinations, equitably distribute the PPE, because in New York State, everything goes to Albany, and they decide who gets what and when and how much. And I think a lot more of it went downstate than it should have. So from an equitable distribution standpoint, could you tell us some of the shortcomings you've experienced, what you've had to do to try and overcome them?
Yeah, I think so. It's difficult too. If you think about the beginning part of the pandemic, when you have PPE and test kits were the big need. The challenge in our state was that New York City and downstate, Long Island, Hudson Valley was really under siege at a greater level. So the state's attention went to that appropriately, went to those regions. But we still had challenges in our where we were. So the model of in an emergency and in a pandemic of just flowing things through the state doesn't necessarily mean it gets to every part of the state. And we saw that with the CARES Act funding. Again, I know there's members of the committee who represent Nassau County. Imagine if Nassau County didn't receive direct aid in the CARES Act, the calls you would have received from my counterparts. We were the largest community in the country that didn't. So we had to make mid-year budget cuts of $40 million in the middle of a pandemic response because we didn't get the help other communities got throughout the country. When you look at vaccine distribution, our frustration isn't at the point the speed. Supply is an issue everywhere. It is that for everything and every curveball we've been thrown during this pandemic, the one thing county governments were prepared to do is vaccinate. We plan and we prepare for that, whether it was Ebola, whether it was SARS. This is what we do. We get federal funding to plan and prepare. And we believe we should have taken a larger role in that, and we still think we can, and especially we think we should, specifically to the idea that we know how to vaccinate our most vulnerable communities better than anyone else because we work with them every day. So with vaccinations, I use sports analogies a lot. We're in the second quarter of a 4-quarter game here. We can learn from what didn't work well in the first quarter and adapt and adjust and pivot to have great success.
Okay, I'm going to follow up on that a little bit more. FEMA doesn't have the discretion with respect to PPE or with respect to vaccinations in New York State, at least, to decide where they go. And to kind of pick up on Chairman Thompson's point, I think because of that, sometimes minority populations do suffer because of the lack of equitable distribution of the PPE and the vaccinations. So would it be fair to say that if FEMA had a little more discretion when a emergency declaration is declared with respect to equitably distributing the products and a better mechanism for that, it would help communities like yours and smaller ones in New York State?
Yeah, if the intention is to get supply directly to us from the federal level, the clearest path to do that is to give it to us. I understand the challenge of there's 50 states and there's thousands of local governments with health departments. I appreciate that challenge, but logistically in a pandemic, I think it's different from regular course of business funding models.
Right, and just to put a little finer point on that, FEMA is dealing with its first national declaration, disaster declaration. It means nationally, they're in charge of getting the stuff out to the front lines, the vaccinations, the PPE and everything. And it seems to me that given that model, for communities like yours and communities like Chairman Thompson talk about Mississippi, they should have more discretion instead of being held to the whims of a governor or a legislature that may not be as competent at doing that. And then from a fundamental sense of fairness, FEMA should have more role in deciding how things get distributed within the state. Is that fair to say?
I think it would be beneficial during the pandemic from my experience, not suggesting we may do some things differently, whether they're better than the state would do them. History will judge us all on that. I just think the reality is local health departments, these are our professionals. We have epidemiologists on staff. Our local health commissioner and their team, they're the best in the business, in my opinion. We know how to get things done. This is our community. I'm a county executive. I'm accountable to every member of the public here. We have certain powers in a public health crisis that have even been somewhat challenged through the state emergency orders. So if the intention of the federal government is to get funding to local health departments in an emergency, the easiest way to do that is to get the funding to us. There's no guarantee if it doesn't go to us that the intention from the federal government, that will is going to actually happen.
Thank you very much, Mr. McMahon. I appreciate all you've done during this pandemic. And Mr. Chairman, I yield back.
Thank you.
Thank you very much. The chair will now recognize other members for questions they may wish to ask the witnesses. I'll recognize members in the order of seniority, alternating between majority and minority. Members are reminded to unmute themselves when recognized for questioning and to then mute themselves once they've finished speaking, and to leave the cameras on so they are visible to the chair. The chair now recognizes for 5 minutes the gentlelady from Texas, Ms. Jackson Lee.
Thank you very much, and good morning to all the witnesses. Thank you so very much for your very important testimony. Texas remains a hotspot in the landscape of COVID-19 cases. It's a state of almost 29 million persons, and we've had 41,000 deaths, and we continue to be a hotspot for infection. And of course, we are challenged as it relates to the hard to reach communities and people of color. So this is a very important hearing because we're not ending, we're beginning. And I think this committee has to be very pivotal in that role. Let me ask Ms. Clowers of the GAO regarding the issue of testing, just a memory lane very briefly, if I might, where we went wrong in the testing protocol when COVID-19 first started. You had recommendations of GAO reporting regarding testing and where they were implemented. What were your recommendations very briefly, and are they valid today?
Yes, they remain valid. One of the key recommendations that we made was for a national strategy, and you've heard the other panel members talk about this need as well. There's been different testing strategy documents that have been put out, but not an overarching strategy that would contain all the information that you would expect from a comprehensive strategy, where it defines the goals and the problems and the risk and the benchmarks, as well as how we're going to fund this, what resources are needed, and defining the roles and responsibilities. And then importantly, making that strategy publicly available. One of the things we found in our work and talking to non-federal stakeholders is that sometimes they weren't clear about their role in a national strategy, and that is ripe for causing confusion and gaps, and that's what you can't have during a public health emergency.
If I might, the failure in the administration not having a testing protocol provided for the surge in COVID positive cases. No testing protocol. No. Okay, go ahead.
I'm sorry to interrupt. The lack of the strategy has certainly compounded the problems that we were seeing. As you know, from the start, the testing in our country had challenges with the rollout of the test equipment from CDC that was caused some inaccuracies into the slow ramp up, and then we got into the supply chain. So it was a snowballing effect.
Thank you. Thank you very much. Mr. McMahon, I was moved, impressed by your testimony. You're obviously boots on the ground, and we thank you for that. I introduced HR 936, Delivering COVID-19 Vaccinations to All Regions and Vulnerable Communities Act, which really was to emphasize FEMA working directly with local counties and cities where you are managing your own health departments. Can you dig a little deeper on how that would work rather than waiting with hat in hand, as you had to do for PPEs, as you had to do for testing, test kits, and now vaccines, would that help save lives? We failed to do that with the Trump administration. We saw that as members of Congress, but how do you see the idea of getting direct collaboration with the federal government through FEMA and reaching these hard to serve communities, vulnerable communities?
Thank you for the question, and thank you for your service. I believe the reality is that we could be partners at the local level with the federal government. I have colleagues that we communicate throughout the country, and they may be called county judges in different parts of the country or different things, but I've spoken to the Harris County executive or county judge about the challenges via our network that we have. We have the local health departments, the experts. My health commissioner is a graduate of Johns Hopkins. She is well renowned. We have followed the data in this process. We have looked at testing as the tool to identify and box in the virus, the risk to our community, and getting us the vaccine directly will certainly help us get to the communities that need to get it, that are not participating at the right levels.
Thank you.
Thank you, ma'am.
Thank you, Dr. Watson. Are we sicker now because we did not have protocols dealing with COVID-19 early on? Is America sicker now? Lost more lives because of that?
I think there's no question of that, Representative, that we have experienced a lot of illness and death, not just from COVID, but also from loss of access to healthcare for other diseases that are critical. Absolutely.
Mr. Chairman, thank you. Mr. Chairman, may I submit into the record delivering COVID-19 vaccinations to all regions and vulnerable communities act? Ask unanimous consent.
Without objection.
Thank you. I yield back, Mr. Chairman. Thank you.
Thank you. Chair recognizes the gentleman from Louisiana, Mr. Higgins, for 5 minutes.
Thank you, Mr. Chairman, Mr. Ranking Member. We have shut down the world's economy and destroyed millions of American families' lives over a virus here. Far beyond the health concerns of the virus, 100 million American adults having difficulties covering their household expenses. Millions of children are missing out in critical in-person education. The economic consequences of government action in response to this virus is going to last a generation. Viruses come and go. There's a certain cycle. The new virus impacts the world responds. We're in the 21st century now. We have unbelievable medical skills and technologies. We're responding very quickly. And yet we've shut down the world's economy. Despite Americans being told to stay home, let me tie this together with what's going on at the border. Americans being told to stay home and shut down their businesses and deny their children an education. But our newly inaugurated president is right now allowing scores of thousands of migrants, illegal immigrants, who had been held in Mexico and attempted to enter our country illegally, allowing them access into America. We're a nation of immigrants, a nation of compassion, and I'm willing to have a conversation about immigration laws with my colleagues, but I find it highly ironic that Americans are being asked to live under continued repressive COVID restrictions, while the Biden administration has relaxed our borders in a way that will result in a mass migration of people from Central and South America. Nobody's talking about COVID there. We expect illegal immigrants to enter America relatively freely, and we should let American citizens ourselves live free. Families have been restricted from the deathbeds of their loved ones. This is an unbelievable emotional impact. At any other time, my colleagues were talking about, we talking about the emotional stress and the pain and the burden of anything imaginable. But no one's talking about this. It's been abhorrent the oppression of freedoms and the impact on American families. And my colleagues and the respected panelists have mentioned statistics. Statistics stating that the U.S. is worst in the world. Statistics are very commonly lies. Compared to who? China? Seriously? Does anyone believe that any COVID data coming out of China is accurate? It's intellectually unsound. What's next, Mr. Chairman? What virus is next? What level of government oppression is next? Many Americans believe that their government doesn't want them to wear masks and tolerate unconstitutional restriction of freedoms until the end of COVID. Many Americans believe that government wants us to wear masks and tolerate oppression until the end of time. We grow weary. Mr. McMahon, let's talk about our kids, please. Let's talk about children in schools. Students at the highest risk of long-term negative effects due to government actions in response to COVID. Parents unable to go back to work because their kids not allowed to go back to school. Give us your opinion, share with America. How do we get our kids back in school? You mentioned in your opening statement regarding Syracuse University. Share some of that formula, how we can get our kids back in school, please.
Yeah, thank you, and thank you for your service as well. The reality is that throughout the pandemic response and every issue, we follow the data, and the more data we can get, you can make better decisions, and you find the appropriate balance at the appropriate time during the pandemic response. Certainly, we're at a position now when we getting, for example, higher education back into the community. We worked with Syracuse University to send test kits to every student throughout the country. They were tested. Those who tested positive needed to quarantine at home. The students then came back to the community that were negative. They were then tested again. Now we do weekly testing for higher ed so that these students can have an in-person experience. When you look at our pre-K through 12 in our community, we've been going to school. Some of our smaller rural districts, due to the regulations set forward by the state, can meet in person 5 days a week because of the physical space. Some of the larger districts have hybrid models where they're going in person 2 days, some not. Some of, in our urban districts, the model changed from a remote model to a hybrid model. We're very concerned about the hybrid models. We know our children are falling behind. We know that we have rising cases of child abuse. Our eyes and ears on our children are our educators day in and day out. We need them in the game. Our kids need to be learning. So we look at the data. Like I said before, what we did before our pre-K through 12 started in the fall, we tested all the faculty going back. We've done random asymptomatic saliva testing in the school buildings to look for that asymptomatic carrier. Now we've been using the Binax antigen tests on a weekly basis with our county teams going in with our schools to test asymptomatic students. Mind you, a symptomatic student is not allowed in the building. So our positivity rates in the schools from the month of January of 2021 to present, even though we were experiencing surges in the community, our positivity rates in the schools is really about a 0.2% trending down. So we believe testing is the tool to keep schools open, to give the data to the public so the public feels comfortable about doing more in-person learning.
Gentlemen from
Thank you, sir.
his time has expired. Let me caution the members that if you speak for 4 minutes and ask a question that takes 3 minutes, you're not being fair to the next member of the committee. So I'm going to hold us to the 5-minute mark because we have a lot of members, because we're in a full committee, who need to get a chance to ask that question. So the chair will now recognize the gentleman from Rhode Island, Mr. Langevin, for 5 minutes.
Thank you, Mr. Chairman, and I want to thank our witnesses for their testimony today. I want to turn our attention to how the disabilities community has been impacted by COVID in particular. Unfortunately, many of the 500,000 people that we've lost to COVID belong to the disability community. Reporting by, for example, NPR shows that people with intellectual disabilities and autism are dying from COVID-19 at higher rates than the general population. And early numbers from the United Kingdom show that people with disabilities accounted for nearly 60% of all COVID-19 deaths last year. A very sobering statistic indeed. As we continue working to provide an equitable response to the pandemic, I believe it's essential that we include the disability community in our conversation. So, Ms. Clowers, if I could start with you, in your testimony, you discussed CDC data that illuminate the disparity in COVID-19 cases, hospitalizations, and deaths when examined by race and ethnicity. Would standardized COVID-19 data broken down by disability status also be useful in ensuring an equitable pandemic response?
Yes, sir, it would. We need better, more granular data on a variety of fronts, whether it's with the disabled population, different racial or ethnic groups. Without that data, it limits our ability to take needed corrective action, to monitor trends, to see where we're maybe experiencing problems, and then attack those problems.
Thank you. And are you aware of any CDC data or reporting efforts to examine COVID-19 cases, hospitalizations, or death by disability status?
I have not seen that, but I will ask my team. We'll go comb through the data again and get back to you if we find it.
Okay, I would appreciate that. I think I think that would be very helpful. And I will say that the American Community Survey conducted by the U.S. Census Bureau examines difficulties in 6 categories: hearing, vision, cognitive, ambulatory, self-care, and independent living. I wanted to mention that. Dr. Riziki, if I could, has the Illinois Department of Public Health been tracking data on the prevalence of COVID-19 cases, infections in the disability community, and why did the state feel it was important to prioritize vaccination for individuals with disabilities?
Yes, sir. Thank you. So we absolutely saw that this was an important group that needed special attention beyond individuals who are in a congregate care facility. And so that's why we intentionally moved the group of differently abled or disabled population into our 1B category. And with our forms of registration for vaccination, we will be able to select, people will have to designate their eligibility for vaccination. So they will be able to check if disability is the eligibility criteria that they meet. So we will be able to grow some information and data around that. That eligibility population begins tomorrow.
Okay, that's helpful information. Hopefully others will look to that going forward. Let me ask you this. It's been reported that roughly a third of America's military personnel are declining to receive coronavirus vaccines when they are offered, which is slightly above the civilian population. Dr. Watson, if I could ask you, from a public health perspective, what can we do to ensure that our troops understand the importance of receiving a COVID-19 vaccine and feel comfortable about its safety and efficacy? And this is also important given the fact that we're using the National Guard, for example, and helping to implement and assist with the COVID-19 response, but also administering the vaccine.
Thank you for that question. Yes, I think it's all about clear and consistent communication. It's also about speaking with individuals who have familiarity with groups that we want to reach, who are trusted by those communities. So we need to reach out to community leaders and give them the information that they can pass on and have conversations with people to try and understand their hesitancy, and then give them data and information that can show them how safe and effective these vaccines are and why it's important for them to be vaccinated.
Yeah, very important, especially as it could impact readiness and response. So I know my time's expired. Thank you, Mr. Chairman. I yield back.
Thank you much. Chair recognizes gentleman from Mississippi for 5 minutes, Mr. Guest. You need to unmute yourself.
Thank you. Dr. Watson, in your testimony on page 3 of your written testimony that you submitted, you have a paragraph that says what we're doing right now in the United States. And you talk about some of our recent successes. It says the number of U.S. cases, hospitalizations, and death are all dropping rapidly from the winter peak, which was the highest of the pandemic. Daily numbers have fallen from a high of 295,000 reported on January 8th to about 72,000 as of January the 20th. Similarly, hospitalizations came down from a dramatic national average of about 130,000 to 63,000. And deaths are following, having dropped from a 7-day average of about 3,500 a day to about 2,000 per day. You also go in the following paragraph to talk about an increase in population immunity from vaccination and prior infections. And you say as of February the 20th, about 12.9% of the United States population has been vaccinated, and more people in the U.S. have now received at least 1 dose of the vaccine than the number of people reported to have had COVID. Recent media reports as it relates to school reopenings. The Wall Street Journal said parents and officials who favor reopening in-person education say their own experiences confirmed research showing that children are being harmed academically, emotionally, physically by the isolation of remote learning. Kids, they argue, need to be back in the classroom as soon as possible. They point to the U.S. Center for Disease Control and Prevention recent urging of schools to reopen under new safety guidelines and research that show low transmission in schools where safety protocols are followed. ABC News reported that the nation's top health agency said that in-person school learning can resume safely with masks, social distancing, and other strategies. And vaccination of teachers, while important, is not a prerequisite to reopening schools. In my home state of Mississippi, the chairman's home state of Mississippi, my son's high school, we have been successfully implementing in-person learning since August. So August, September, October, November, December, January, February, now heading into March, for 8 months in the state of Mississippi, we have been able to successfully implement in-person learning. Congress has appropriated $70 billion for K through 12 schools to implement and to educate our children during this pandemic. And so my question is, in light of the recent successes that you listed in your report, in light of the new CDC guidelines, in light of the fact that Congress has appropriated $70 billion, why are we still unable to reopen our schools in many parts of the country?
That's a good question. Thank you very much. I think that we still have very high incidence of this virus in our communities. And so as incidence continues to drop, it's not low yet, but as it continues to drop, it makes in-person learning much safer. I agree with you that when schools follow the CDC guidelines, when they're testing frequently, and especially now that we have vaccine, when adults can become vaccinated in schools, that in-person learning will become much more viable and much safer. So I think we're definitely headed on the path to resuming in-person learning for most schools across the country. But we have to do it safely, and that's through following the CDC guidance.
Do you agree that children that are educated remotely, that they suffer harm academically, emotionally, and physically because of the remoteness? And would you also agree that there are many children who learn much better in-person classroom setting than they do remotely?
I think there's no doubt that in-person learning is what we are all striving for and what kids need. We just have to make sure that we're getting back to it safely, and I think we're on the path to that.
Well, then why are schools such as schools in Mississippi, again, where my son has been enrolled in-person learning since August, why are some schools able to be very successful in that and other schools are even reluctant to try in-person learning because it seems like from the recent CDC guidelines and the new research that we're getting that schools can reopen safely, but is reluctant on behalf of many of the educators, many of the school boards to force schools to reopen and to educate our children as they are being, as we are required to do.
The guidance is also dependent on lower levels of transmission in the community, as well as comfort by teachers and other adults who have to be in the room, as well as parents in sending their kids to those schools. And so it has to be a conversation with people. We can't force people to come back in person if they're not comfortable.
Thank you, Mr. Chairman. My time's up. I yield back.
Thank you very much. Chair recognizes the gentleman from New Jersey for 5 minutes, Mr. Payne.
Thank you, Mr. Chairman. In listening to my colleagues, I'd be remiss if I didn't mention that had the 45th president taken seriously this pandemic, we could potentially not be in this condition. 505,000 people, 505,000 people have succumbed to this disease. And the 44th president met with the 45th president's administration and laid out 3 different incidents of disasters that could happen in the country. And one was a pandemic scenario, but it was never taken seriously by the 45th president. And here we are. So my question is for Dr. Ezeki and Dr. Watson. Now, getting our children back into school is critical, but we must do it safely, obviously. President Trump pushed schools to reopen, but without funding, states and local governments need to ensure distancing in schools and enough PPE for students and educators. He would not even reimburse state and local governments for the costs necessary to operate schools safely, such as masks or disinfectants. My piece of legislation, the Mask for Students Act, which passed the House unanimously last Congress as a part of the FEMA Assistance Relief Act, would require FEMA to reimburse school districts for the cost of masks. I'm pleased that President Biden has followed our lead and directed FEMA to reimburse schools for these operating costs. Dr. Ezeki and Dr. Watson, can you explain to the committee why it is important for the federal government to help schools pay for mitigation measures like masks and disinfectant supplies?
Thank you, Representative. This is an important measure that's needed because all school districts are not created equally. We know we have school districts in high socioeconomic areas versus very low socioeconomic areas. And so the ability to have these supplies on the ready without the assistance is very varied. We know that class sizes, classroom size, the ability to do testing, a lot of those measures have been able to be done in higher economic areas, which causes the increased disparity. So we do agree that resources should be deployed so that that is not another defining division to be making some students have opportunities to be in-person learning versus others, because we do all agree that that's where we want our kids to be.
Thank you. Dr. Watson?
Thank you very much. I completely agree with my colleague. I also think that we need to give consistent guidance to school districts across the country that's coming from the federal level, which I believe we now have, but also from the state and local level, which has been quite variable. So if we can make clear our expectations of the steps that schools can take to keep their students safe and then provide the resources to do that, I think that will be very helpful.
Thank you. And Mr. Chairman, I yield back.
Thank you, gentleman. Yields back. Chair recognizes the gentleman from North Carolina, Mr. Bishop, for 5 minutes.
Thank you, Mr. Chairman. Dr. Watson, your testimony happened to be first in my packet, and so I read it with care. In this first page, you say that significantly, though, we also have evidence that our national response did not meet its potential and that many thousands of unnecessary deaths have occurred as a result. So I read with care specifically those parts of your testimony that spoke about successes and failures. I note, I guess this paragraph on page 5, you say finally, and I think this is everybody pretty much agrees on this. It's saying finally, the biggest and most visible success of the past year is the development of multiple highly safe and effective COVID-19 vaccines in under a year. I cannot emphasize enough what a technical feat this is. And in fact, you've said also otherwise in your report that cases are dropping sharply and hospitalizations are at this point. Is that right?
Yes, that's correct.
And so by historical standards, I mean, that's kind of an unprecedented success, wouldn't you say?
I think the development of vaccines is absolutely an unprecedented success, yes.
Now, on the parts about the failures of the U.S. pandemic response, I read that, and it's hard for me to condense some of it. I mean, it's about, you said that public health officials suffered retribution and bad treatment, that elected leaders didn't adequately protect and support them. There was a politically driven failure to heed expert advice. I think this is the best summary sentence maybe. It says high-level denial of the severity of the pandemic and disempowerment of scientists and public health experts led to both under-resourcing of the response and significant confusion of the public. So when you get past that sort of section on just sort of the generalities of that, you get into a paragraph that says, within the response itself, there are a few significant issues that should be highlighted. You say that public health agencies are overburdened and underfunded, and then you come to a specific. You say support for state, territorial, and tribal vaccination planning is a particularly damaging failure. While the U.S. government has understandably spent billions of dollars on vaccine development, only $200 million was provided to states for the actual distribution and administration of the vaccine. Is that, in fact, your testimony? You cited an article, but is that your testimony before the committee that only $200 million was spent for that?
Was specifically made available for the planning and for mass distribution of the vaccine, yes.
Well, I looked at the article that you cited, and it says that $200 million was released by CDC in September, and in fact, there's a September 23 release to that effect. But at the end of the article, it goes on to say Congress eventually did allocate $4.5 billion to state governments, but the money only began to flow to states earlier this month. So it's a figure 200 million or 4.5 billion?
200 million was in reference to the planning phase for mass vaccination back in the fall.
And at the time, I mean, that was only released in September. So the debate that this newspaper article refers to was happening in October, right?
Yes, sir.
I think what caught my attention about it is when I was reading Ms. Clower's testimony over on page 5, it said that FEMA, as of February 7, had provided more than $2.29 billion to 32 states, the District of Columbia, 3 territories, and 2 tribes for expenses related to COVID-19 vaccination efforts. So there's another, is that an additional $2.29 billion? Because it didn't come from CDC, but FEMA.
I would refer to my colleague, Ms. Flowers, on that specific issue. I'd have to go back and look, sir.
When you were testifying that only $200 million has been given to health distribution efforts, you were intending for us to rely on that information. I assume you researched it carefully, didn't you?
Yes, sir. That was the funding that came from CDC to state and local health to state health departments to prepare for vaccination efforts. Yes.
Well, I would say that from what I've read in your own article and from Ms. Clower's testimony, that seems to be a misleading figure. And I would think, in light of the degree to which you anticipate and expect that people rely on you as the expert, that you would be more careful about reporting such a disparity. I mean, we're talking about probably 100 times a misnomer or mistake in terms of the amount there. I noticed that, or point out, I'm sure you're aware that in New York State, Attorney General Letitia James released a report on the nursing home response there, and that a larger number had died than had been reported, that there were suppressions of information by the state government there because for political reasons, that the number of deaths connected to New York nursing homes were about 15,000 up in the that's ballooned up to that from 12,743 in late January. So it's an ongoing problem. And I would think that it would be very important to maintain trust that accurate and nonpartisan, non-slanted information come forward from public health officials in order to justify the confidence and the reliance that you are saying should be customarily accorded. Thank you, Mr. Chairman. Time's expired.
Thank you very much. Chair recognizes gentleman from California for 5 minutes, Mr. Correa.
Thank you, Mr. Chairman, for holding this most important hearing. Last year, as you know, I was the first member of this committee to call for expert testimony about this emerging threat called the coronavirus today. And this committee, thank you very much, sure, was one of the first to hold a committee hearing on this subject matter. A lot has happened in almost a year, a lot of loss. A lot of our friends and neighbors have passed on. Ms. Clowers, in a GAO report on our COVID response, you noted that the previous administration had not acted on recommendations to more fully address critical gaps in the medical supply chain. Lessons learned. Where did the prior administration fall short? What do we do today to fix that?
We made several recommendations in the area of medical supply chain, and I'll highlight a few where I think if we took some action, it would help improve ongoing response. First, clarifying the roles and responsibilities of the number of actors involved. At times, there's been a lot of maybe phonetic activity in trying to get the supplies and address the gaps that we're seeing, but they always haven't been coordinated, leading to confusion and frustration.
Let me interrupt you there very quickly. You bring up a good point. And Mr. McMahon, you're a county individual where the rubber meets the road. One of the issues that I see on every weekend that I'm out with my county employees trying to vaccinate our communities is as you said, Ms. Clowers, confusion. And I'm seeing some of the change in the administration's response, this administration, to use federally qualified healthcare centers to better communicate, distribute vaccines directly from the federal government to those people that are actually giving out the vaccinations. There are too many middlemen right now. There are too many different agencies, state, local, counties involved, and this is creating all kinds of confusion. So my question to both of you is, how fast can we get the federal government to streamline the system, use FQHCs, maybe go directly to those, doctors at the corner that really treat the patients on a day-to-day basis? How can we execute more effectively right now and not have to wait another few weeks to get to an execution that is satisfactory to our community? You can answer that very quickly, Ms. Clowers and Mr. McMahon. Thank you very much.
Okay, I'll go first, Mr. McMahon, if you want, and I'll just say really quickly, it's involving local officials like Mr. McMahon in these efforts. To date, a lot of the plans have been developed maybe at the federal or state levels and not always involving the locals, and the locals are the ones that know their community and can get that message out and help get the distribution going. And so I'll turn it to my colleague now.
Mr. McMahon.
I would agree, sir. The reality is our local FQHC has been a great partner of ours. We had the first mobile testing site with them before we had a case. The challenge they would have would be capacity. So we at the local level have the capacity. We have the human service relationships in the neighborhoods. The state of New York's working with us potentially on more vaccine supply to address this issue. But we are the ones that have the existing infrastructure that we can build off of. We have the relationships. These are our clients that we work with on a day in and day out in other departments. So really at the local levels, the best way and the best strategy to get to our hard to reach communities.
Ms. Clowers, we keep talking, we keep reading about these millions of vaccines that are coming our way. Yet this last weekend, I was at home. Mega centers shutting down because the vaccines weren't there. How fast can we ramp up to really take care of this issue? I don't want the blame game. I just want to say, how fast can we get the vaccines to Main Street?
Well, I think we heard very positive news out of testimony yesterday from the vaccine development companies in terms of getting to 3 billion doses in the next month or so. And so the supply is growing, the supply is going to be there. It's really going to come down to these logistics of taking what the supply there and quickly getting it into the shots and into the arms of Americans. And so that's going to involve our local officials, but also importantly, the communication. It needs to be very clear and consistent, as you've heard from fellow panel members, in terms of both educating the public on and the safety of the vaccine, how to get the vaccine, as well as educating providers and encouraging them to help understand and promote that message as well.
Thank you very much, Mr. Chair. I'm out of time. I yield.
Thank you very much. The chair recognizes the gentleman from South Carolina for 5 minutes.
Thank you, Chairman and Ranking Member Katko. Thank you for holding this hearing. I guess my question concerns the vaccine rollout. And let me remind my colleagues my friends on the left, that had it not been for Operation Warp Speed to produce this vaccine, there would be no vaccine. So other than the seven-year turnaround, which is normal, to have it within 12 months is really an accomplishment that the 45th president made happen, and I just wanted to alert everyone to that. Let me ask a question as far as the rollout. We've got right at 3,000 immigrants a day coming across our border due to the Biden administration. I've heard all through this testimony about shortages of vaccines among the minorities, shortages among Americans. What are we doing as the 3,000 come across the border who will be entering our school systems, who will be into our towns? What is our game plan to vaccinate them? Are we using masks? What's happening with that? Because if you look at the statistics, and I'm one that follows the data, I think that's a good thing. The new cases domestically, according to the CDC's website, are 67,437. Internationally, they're 384,448. You look at the new deaths domestically, 2,356, and this is as of February 19th. Internationally, 10,471. So 5 times the numbers domestically. So in order to protect America, and Ms. Clowers, I'll address this to you, what is the game plan that you see to fund it for the illegals coming across the border, and how are we going to deal with this?
Well, certainly, as we roll out with our vaccine efforts, and we're focusing on the United States, as one of the panel members mentioned earlier, this is a global crisis, and as long as the pandemic, the virus is spreading throughout other countries, that poses a security risk and a health and safety risk to us as well. And so it is something that we're going to have to watch and participate in. I know there's been funding that's been provided through state and other efforts to help control and mitigate the spread in other countries, and it's work that we have ongoing, and happy to report back to you on this.
So specifically, are they being vaccinated as they come across, or are they being tested? Give me some, I know you say generally we're looking at it. What are the specifics?
Sir, at this point, I don't have those details at my ready in terms of what we're doing at the border, but I can certainly get back to you and your staff on that.
If we could, because it affects every American, this isn't a Democrat or Republican issue, this is an American issue. So if you could get back with us on specifically what is being done all across the borders that are now pretty much open for anybody to come across. I'd like to see the game plan that you have and others have before it gets to the pandemic, worsens the pandemic that we have here.
Yes, sir.
Now, as we try to get a handle on the funding, on how the COVID relief is being spent, was your team at GAO, Ms. Clowers, able to assemble the information that we need to track how the COVID-19 relief funds were actually spent, and how was that done?
We are doing that in the process of doing that. As new relief bills have been passed, we've been updating our information. As of now, about $3.1 trillion has been appropriated, and that's gone across the government, a variety of sectors. HHS has been one of the largest recipients of that, given their responsibilities for the public health. And we've been tracking that down through the obligations that have been made, as well as expenditures, and trying to track that down all the way down to the state and local governments in some cases.
And on the unspent funds, do you know the amount of unspent funds and when that's going to be released?
In terms of, I can give you some information on that in terms of the amount that has been obligated. This is a little bit dated because we're still updating the information, but as of November 30th, when so far at that point, $2.7 trillion had been appropriated, about $1.9 trillion had been obligated, and 1.7 had been expended. And we'll be updating that with the new relief Consolidated Act numbers that were passed at the end of December.
Okay. Well, I would ask if you could get this, when do you think you'd have this information?
Yes, sir. We'll be reporting out again in March. Congress directed us to report on a regular basis. So our next report will have the latest spending figures in it. And we'll make sure to get that to you, and happy to brief you and your staff on it as well.
And on the actual plans on treating on the illegals, how's that? Will that be to us?
Yes, and I can get that to you as soon as I get back to my team and get some specifics in terms of what the agencies are doing, and a follow up with your staff.
Great, thank you so much. I yield back, Chairman.
Thank you very much. Ms. Watson, I did not give you time to respond to the testimony referencing the CDC expenditure for the vaccine. If you'd like to respond to that, I'll yield back to you.
Thank you very much, Chairman. Yes, I was specifically referencing the funding that went to state governments, to health departments, to prepare for the vaccine rollout. And so at that time, it was a very small amount compared to what had been spent on vaccine development. And that development was obviously very important. I'm not taking away from that, but we did not adequately resource our health departments to undertake this unprecedented rollout of vaccine, certainly.
Thank you very much. Chair recognizes the gentlelady from Michigan, Ms. Slotkin, for 5 minutes.
Thank you, Mr. Chairman, and thanks for the witnesses for being here. My question is related to this supply chain issue. And I'm sure everyone on the screen went through the experience back in, April, March, where we were just desperately trying to get a hold of masks and gowns and gloves and very basic things. And I remember very clearly being on the phone with Chinese middlemen in the middle of the night, just trying to get some KN95 masks for our healthcare workers who were using things like scuba equipment in order to protect themselves as they intubated patients and whatnot. And then I remember very clearly when we got our portion of the strategic national stockpile, it was a lot less than what we thought. We opened it up, it was moldy and expired. And for us in Michigan, I feel like we've been talking about how when you outsource supply chains, particularly on sensitive issues, on sensitive items, like it's gonna come back to bite you. And I feel like it bit us. So the question is, we have the president at the White House today announcing a new kind of Made in America supply chain review. For Ms. Clowers, can you just go through in specific terms what additional steps we need to take to, if not bring back some of that supply chain to the United States, at least regionalize it so we're not dependent on countries we have sometimes mixed relationship with, like China? What can the Defense Production Act and Buy American requirements in the government do to actually bring those supply chains home or make us less vulnerable?
Yes, this is an issue that we've been tracking for about 9 months now, because as you note, it's been a persistent challenge from right at the beginning, from the lack of supplies. And what we saw was that domestically there was an insufficient amount of supplies on hand, or in some cases they were outdated. The supplies were unusable. In terms of what what can we do going forward. We've called for a few things, including better clarifying the roles and responsibilities of all the different players. Again, we saw that confusion in terms of who was going to be providing what and how to get that supplies that were needed. And I should note that this isn't surprising because in the fall of 2019, the government conducted a pandemic exercise. And through that exercise, they found some of the key findings was that we had insufficient supplies and that we were going to have confusion and that it was going to lead to needed gaps. And in terms of going forward, so we've called for clarifying the roles, assessing what gaps exist now, but also looking ahead to try to get ahead of this a little bit, both, 6, 12 months, and also looking into the next pandemic. We do want to be looking at all the tools that are being used from the Defense Production Act and other tools that we might be able to bring to bear in terms of financial incentives. And two other quick points I'll make on the financial incentives, especially in the area of medical countermeasures. We've been, as we've noted, the vaccine development, we were successful this time in terms of getting a vaccine developed within a year, but that's an inherently risky process that's very costly. Most medical countermeasures actually fail, and so we need to incentivize companies to work in this area, conduct the R&D necessary. And then finally, really examining the role of the strategic national stockpile. Is it to be a frontline defense or a backstop? People need to have an understanding of what they can count on from the strategic national stockpile so state and locals can plan.
Yeah, and I think the truth is Democrats and Republicans all talk about this, right? It's like a really common message that people are saying after the year that we've lived through. But what I have failed to see is actual action, right? We all know we got to look at gaps, we got to coordinate better. But what are we going to do to actually incentivize that production to be made here? That's going to take breaking some China for how our system works. And Mr. Chairman, I would offer we could do maybe a bipartisan letter or something, particularly to DHS, to talk about our concern about this and urge them forward so that we get beyond this idea that we're all concerned and we actually start seeing changes in how they procure at places like DHS. And with that, I yield back the rest of my time.
Well, staff will get with the gentlelady from Michigan and we'll start drafting language for such a letter as you're talking about. Chair recognizes the gentlelady from Tennessee, Ms. Harshbarger, for 5 minutes.
Thank you, Mr. Chairman. I have several questions. The first is for Dr. Watson. I've been a pharmacist for 34 years, and I absolutely understand the vaccination process and the manufacturing supply chains. I was looking at the testimony from Ms. Clowers, and what it says is that in nursing homes, they did not capture the first 4 months of the pandemic because they weren't required to until May of 2020. My question to Dr. Watson is, how important is accurate data collection as we continue to respond to this pandemic? And the second part is, how do we ensure that data collection is consistent from state to state? What kind of parameters are in place to make sure that happens? Because this has to be data driven. There can't be any gaps in this.
Thank you very much. Yeah, I completely agree with you that it should be a priority. And as my colleagues have already stated, in order to make changes and to recognize where our response falls down, we need the data to drive that. So I think accurate data collection is very important. And how we do that is having very consistent guidelines and guidance from the federal government. So from the CDC in particular, that's really important to standardize how our data is collected. Thank you.
That's great. I do agree with my colleague, Ms. Slotkin, because I've been touting for 25 years that we need to do something about the supply chain, being able to have a domestic supply chain for finished pharmaceuticals as well as chemicals to produce those domestically. And it's imperative we do that. And maybe it is a bipartisan letter, I don't know. But what we did learn, and Mr. Norman touched on this, Warp Speed did provide us a vaccine in record time. And that really shows that these drug companies can get vaccines out from now on in a more timely fashion. And it's not just that, it's other things as well. There's a lot of scrutiny when it comes to getting things to market. But Congresswoman Jackson Lee asked you, is our society sicker now than it was before? And you said yes. Now, I read in your testimony that the post-COVID syndrome, there's certain things that we have to worry about with that. And I understand that that's things like loss of taste and smell, fatigue, that type of thing. I've read some articles that say that lasts 8.9 days, and then 98% of people are cleared up within 28 days. So in your testimony too, really 28 million reported cases of COVID. What work's being done to understand those long-term impacts of the virus? In my opinion, the long-term side effects are things like the school closures. You know, when are they going to do studies about what this detriment has done to the children and their learning capabilities? It put us back 10 years. You know, the closures or shuttering of small businesses completely. These are things that I look at, but what are you doing? How are we going to study the long-term impacts of this virus?
I think certainly we need to study all of the long-term impacts of this pandemic, and that includes the societal impacts from the pandemic itself and from the efforts we've had to take to control it. But in terms of the long-term impacts of COVID and post-COVID syndrome, I know that there are a number of studies ongoing now to try and understand what those effects are and how we can help people to recover more effectively from this virus. But recent data has shown that many people, months after they have recovered from the acute phase of COVID, do have at least one of these symptoms, and it's affecting their lives. So I think that's a really important thing that we need to look at.
You also spoke about different variants of this COVID-19 virus. You know how many have been identified or how bad those strains are going to be? I was on another conference call and they talked about those different strains. And what have you learned about that, or what should we know about that?
I think we are trying to increase our surveillance across the country for these variants of concern, and that's a really important effort. That there's funding in the American Rescue Plan for additional surveillance capabilities, and I think that's very critical. Some of the variants are very concerning right now, particularly B.1.1.7, which has been shown to be much more transmissible. We're watching that to see if that will cause another spike in cases in the spring. I'm hopeful that it will, because we have mitigation measures in place. But there are other variants that also escape our immune response that we need to watch carefully, and then plan our updates of vaccination in line with those.
Young lady's time has expired. Still recognizes the gentleman from Missouri for 5 minutes, Mr. Cleaver.
Thank you, Mr. Chairman, and thank you for having this hearing. You know, one of the worst things that's going on in this country, and I have fear for my children and their children over the direction we're going. We try to politicize everything. It almost made me throw up to just hear that. I mean, we have to politicize a pandemic. We politicize wearing masks. We politicize whether we drink out of bottled water or make a cup out of hand, drink out of the faucet, or drink out of a well, whatever. It doesn't matter. We figured out how to politicize it and create some kind of a social battle on it. We've done it here. It just troubles me, but what I would like our guests, those who are testifying, to help me understand is that, the last March, the president said, we want to be back in church by Easter. In my real life, last year was the first time I wasn't in church on Easter in my whole life, but I'm usually there 52 Sundays a year. And then he said it's going to be a great experience. And I think when we start giving out false information, it does damage. My question to you is there a system that we need to put in place? Can you help me at least figure out a way, something we can put in place that will allow the government, to take a back seat because of the system we put in place. And I know we're going to need presidential leadership on things like this, but maybe there's something I'm overlooking. I've been trying to figure out what could we have done to prevent what was done that has, in fact, probably cost us lives. Can any of you help me create this and get the Nobel Peace Prize? Okay, anybody else?
Well, sir, I would offer, as we've looked back over the last year in terms of our work, some lessons learned that have emerged. And actually, these were lessons we also offered actually last February. I was testified before a Senate panel as we were learning about COVID-19 and looking back through our work on H1N1 as well as responses to other public health emergency. Several things were clear about what we needed to be doing. And I've mentioned some of them already, but we needed plans in place in terms of clarifying roles and responsibilities. Everyone needed to know what they were responsible for and who they should be working with. We needed clear and consistent communication in terms of messaging about where we were with the pandemic, what we were doing, and importantly, what steps we needed the public to take. Because in a public health emergency, you're asking the public to take certain steps. And so you need to make sure that you're and informing them in a clear and consistent way. The same thing in terms of using data to drive decision was another lessons learned, and making that data as readily available and understandable to the public so they understand why we're asking them to take certain measures. And then finally, with transparency and being as transparent with their actions as possible. So when the government is making decisions, whether it's around testing guidance or improving emergency use authorization, the public understands, and it can increase the confidence level in the actions that the government's taking.
Thank you. Thank you very much. Mr. Chairman, I yield back.
Chair recognizes the gentleman from Georgia for 5 minutes, Mr. Clyde.
Thank you, Chairman Thompson. I would like to take this opportunity to address my grave concern with the Biden administration's decision to eliminate the migrant protection protocols. This reckless decision will have the dual effect of putting Americans at risk of exposure to the coronavirus and creating conditions that mirror the 2019 border crisis. The increasing number of unaccompanied minors and families illegally crossing the border in the middle of a global pandemic is creating a recipe for disaster. President Biden's executive actions have the potential to cause mass outbreaks at facilities and ports of entry, which would lead to their temporary closure that could have a significant impact on commerce and further handicap our economic recovery efforts. A mass outbreak would also jeopardize the health and safety of our men and women who serve on the front lines protecting our nation's borders. Finally, these executive actions and a surge at the border have forced Customs and Border Patrol officials to return to the dangerous policy of catch and release. This policy releases migrants who have not been properly vetted or sufficiently tested for coronavirus into our communities, putting the health and well-being of Americans at risk. The Biden administration's actions are unacceptable and serve as distractions from what this committee should be focusing on, which is how we can secure our borders and prevent our constituents from being exposed to the COVID-19 virus. I would like to submit for the record a letter that my colleagues and I on the House Oversight and Reform Committee sent to Secretary Mayorkas highlighting these concerns. The letter is dated February the 19th. With that, Mr. Chairman, I yield back my time.
Thank you very much. Without objection, the letter will be included in the record. Chair
Thank you.
recognizes the gentleman from Texas for 5 minutes, Mr. Green.
Thank you very much, Mr. Chairman. I am honored to have this opportunity to ask questions. Let me lay a predicate. President Trump led 3/4 of the 69 press events during the first 13 weeks of the pandemic. First question, how important is it for the professionals to give professional advice at the inception of a pandemic when it's in its nascency. Dr. Watson, would you kindly respond?
Yes, sir. The professionals, the public health experts, the scientific experts need to be able to provide their expert judgment on the pandemic situation. And it's not always totally clear cut what the situation is, but they need to be able to weigh in with their experience and education and the related judgment. When they're prevented from doing that, or when political pressures are put on them to say something that contradicts that experience and that judgment, that's where we run into problems.
I think it's fair to say that, and I mean no disrespect, but that some of the advice that was given by the president, some of that advice proved to be harmful to some members of the public. I can recall persons taking certain chemicals to their bodies that were harmful to them. Is this the kind of thing that you can avoid if you allow the professionals to lead?
Yes, sir. Good risk communication will tell people what they can expect in terms of risk, what actions they should take to protect themselves, and answer the questions that they have, but won't lead them to do things that are more dangerous.
Now, on the other hand, juxtaposing the Biden administration to the previous administration, we have the Biden administration with a commitment to put shots in arms. And in fact, in my congressional district, the Biden administration is setting up a super site, 6,000 shots in arms per day, to have a total of 126,000 people vaccinated. This is coming from the federal government in concert with the state, the county government, and the city. This is a collaborative effort. Is this the kind of effort that you need in a pandemic so as to thwart the pandemic as quickly as possible?
My colleagues and I like to say that pandemics break systems. And so what we need is people to come together at all levels of government to address this unprecedented challenge. And yes, that's the type of coordination that we need. Thank you.
And finally, this, minority communities are especially vulnerable, multiplicity of reasons why. But it appears to me that we have to do more in terms of assuring minority communities that they will get the vaccine. But on the other hand, we also have to assure minority communities that this vaccine is going to be safe. There's good reasons for minority communities to have consternation about injecting vaccines into their arms, given the history that they've suffered in this country. But what would you say to the minority community in my city that may be watching now because of certain circumstances that have occurred? What would you say to them to encourage them to please get these vaccinations?
I would say that I understand that there is a history of abuses that has made it difficult to trust both government and healthcare systems. But I would encourage individuals in your community to listen to their local leaders, to try and understand the facts about the vaccine in particular, and to judge for themselves how safe and effective it is. And I hope that will give them the information they need to make it a good decision.
Thank you, Mr. Chairman. I yield back.
Thank you very much. Gentleman yields back. Chair recognizes the gentleman from Florida, Mr. Jimenez, for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. Dr. Watson, a couple of questions for you. You state in your testimony that certain countries were very effective in keeping the virus out. What are those countries? Which countries were they?
There are a number, but the ones that I have in mind are particularly New Zealand and Australia right now. Those are the ones that I have kind of held at the top of mind, yes.
And what do you account that? How do you account for that? Why were they able to keep it up?
Yeah, there are a number of factors early on. They took very quick action to prevent cases from coming in, to identify cases early, and then to take the public health actions to prevent those cases from turning into epidemics by finding every case as much as possible and then doing contact tracing and ensuring that the transmission didn't continue.
And they were able to return to basically a normal kind of existence, normal kind of life in those countries?
Yeah, in some cases that life has looked pretty normal over the last several months, with the exception of if there is an introduction of a case, then those countries often take pretty rapid action to shut things down to prevent epidemics, but then they're able to return again to more normalcy.
Are they open to the world, or are they shut off from the rest of the world?
I don't know. I don't have the facts fully on that, but I think mostly that things have slowed. Like with the rest of the world, transportation has slowed. And so it looks largely like the rest of the world in that way.
Do you know if we test the migrants coming in on the southern border? Do we test them for COVID-19?
Like my colleague, I don't have that information, but I'm happy to get back to you on that.
Does anybody on this call have that information? Okay, and also, do you know if we are testing, I guess nobody has the answer to that, if there's a different variant that they're bringing in from the south? Because I understand that the Brazilian variant of COVID-19 is very similar to the South African variant, which is resistant to the vaccine.
I think the data on that is still a little unclear about the P1 variant, but what we do know is that these variants are already here in the U.S. And they've been identified in many states already.
Okay, I think final question is, do we know the percentage of Americans that are refusing to get vaccinated?
I'm not up on the current number on that. I think there have been some significant polling, but I'm not sure what the most recent number is.
And what number would that be that would make the vaccination program less effective, let's say, to getting back to a normal life?
I think we need to aim for a high number of vaccinations around the country. In our very vulnerable populations, we should aim very high in the 80% range. In the general population, it's hard to pinpoint an exact number, but I think we need to reach at least 60% of people vaccinated. That should be our goal. But there is no hard and fast number to say that it will be a success or a failure.
Okay. And do we have again, I know that I heard somewhere else, I guess in another hearing, that there is a variant. The variant from South Africa is resistant to the vaccine, but if you do get vaccinated, even if you get sick with that variant, that you won't die. I mean, it will be much milder effect. You heard that also? Have you heard also that?
I think the data we've seen so far shows that vaccines have been highly protective against hospitalization and death against many of these variants. And so that is a hopeful sign.
Is there any variant that you are afraid of?
I am afraid of those variants that escape our immune responses, whether it's natural immunity or vaccination. And so I think we need to track them very carefully, and we need to plan for the future of the pandemic in this country. We may need to update our vaccines to respond to these threats.
Okay, thank you very much. I appreciate it. Yield back my time.
Thank you, gentleman. Yields back. Chair recognizes the gentlelady from New York for 5 minutes. Ms. Clark.
I thank you, Mr. Chairman, and I thank our ranking member. Approximately 1 year ago, life as we knew it came to a screeching halt. Within that year, COVID-19 has claimed more than 500,000 lives. This many deaths did not have to happen. For decades to come, we'll look back at the previous administration's handling of this crisis as a textbook case study of how not to handle a pandemic. Fortunately, President Biden has made it clear that going forward, we will let science, not politics, guide our response. I happen to represent a district that has been particularly hard hit by COVID-19 as part of the epicenter of the outbreak of the pandemic. We all know that communities of color have borne the brunt of the pandemic. Brooklyn is one of those areas, and it is also home to countless essential workers, many of whom are immigrants. They are the heroic front line, the lifeline, and most vulnerable all at the same time in this pandemic. They are a significantly crucial segment of the population of our communities in New York City who have faced some of the highest infection rates in the nation. We must rapidly address the inequities in public health and eliminate the disparities from our COVID-19 response. Having said that, I want to turn your attention to Project Air Bridge. I have to tell you, living in New York when we had to scramble, outbid, and do everything we could without the help of the Trump administration because the states were handling it, to Project Air Bridge, to see Robert Kraft's airplane land at JFK with the New England Patriot sign on it and not a B-59 or whatever the plane is from our National Guard or our military was such a slap in the face to Americans. Over the past year, when it came to securing PPE for frontline medical workers, I certainly know why New York had significant struggles. The Trump administration repeatedly touted Project Air Bridge as a success story in accelerating the importation of critical PPE. FEMA indicated that at least 50% of its supplies were directed to hotspot areas. But there was a serious lack of transparency to confirm this occurred. As a matter of fact, it looked like a rewarding of some friends, i.e. New England Patriots. Despite repeated requests, we never received information on where the supplies went and other basic details. I raised this at the committee's July 14th hearing. Dr. Ezike, when it comes to securing PPE, could you share with us your thoughts on how states were forced to compete to secure PPE in what Governor Pritzker told the committee was akin to the Hunger Games, and the degree to which Project Air Bridge was effective in meeting Illinois supply needs?
Yes, thank you, Congresswoman. Significant challenges in the securing of PPE, as I think another representative who was in the struggle last year, we were talking to middlemen in various countries in China. You know, I got a guy. We were sometimes outbidding, trying to bid or outbid other states. In one situation where we did have an arrangement to have a large shipment, we then got outbid. Our order was canceled as the federal government was out competing us. We had to, at one point, actually take state police to the airport to make sure that there wouldn't be any interception of a shipment that was coming in. So very uncharacteristic moves were undertaken to secure this life-saving PPE for the pandemic.
I thank you, Dr. Ezekiel. Let me just say that was a disgrace. And we need to really unpack what happened with Air Bridge and make sure it never happens again. With that, Mr. Chairman, I yield back the balance of my time.
Thank you very much. Gentlelady yields back. Chair recognizes gentlelady from Iowa, Ms. Miller Meeks, for 5 minutes.
Thank you very much. I was trying to unmute myself. I appreciate it, Chair. If I could, I have a couple of very quick questions and then a more lengthy question. So, Mr. McMahon, you mentioned the local public health and local public health funding, and both as a physician and the former director of the Iowa Department of Public Health, I'm wondering, and this is one of the things I advocate for, is that rather than money that's allocated to the states, and then the state decides, could there not be funding go directly to CDC and then go to local public health grants, which would then go to our local public health agencies? Would that not be a pathway for us to get funding to local public health agencies so they both have adequate PPE and can vaccinate?
Yeah, I think anytime if the intention is to get us the funding, finding a way to get us directly guarantees you get us the funding. We have great relationships with our state partners, but certainly there are times where funding goes to the states and it doesn't flow back to the local governments.
Yeah, I had that same conversation with my local public health agencies. And then, Dr. Ezeki, do you know what the number of non-COVID related excess deaths are in the United States with the pandemic? I ask that because in San Francisco, published in January of this year, I've referred to this pandemic as life versus life. In January this year, San Francisco Chronicle published that there were 699 deaths from overdose. It would have been much more than that had it not been for dispensation of Narcan. And this was 57% greater than in 2019, so vastly outstripping. And the number of COVID deaths in San Francisco at that time were 121. So do you know the number of non-COVID related excess deaths in the United States during the past year?
Doctor, we have that number. I don't have it at my fingertips, but our team can get that back to you. But I think we had it was at least 20 or 30% on top of the known COVID deaths. And so we would say that those may have been some missed COVID deaths as well as other non-COVID deaths within that number.
Yeah, so over the summer, I had found a figure of approaching 98,000 at the end of summer. My next question, and this can be to Ms. Clowers or any of the panel members, but again, as a physician and former director of the Iowa Department of Public Health, one of the most concerning things to me at the start of the COVID-19 pandemic was the issues of our country had with supply chain of pharmaceuticals and PPE. And given my time in the military, the supply chain is very concerning to me. In particular, I was concerned about our country's ability itself to produce medical supplies domestically. As you know, last spring, the Chinese Communist Party issued threats to cut off the supply of medicine to the United States, just as the virus was beginning to spread widely in our country. Thankfully, the Chinese Communist Party did not act on that threat, but it exposed the vulnerability of our medical supply chain when we rely on foreign countries and foreign nations for these critical supplies. And some of the supplies that some countries received were inadequate or deficient. So Ms. Clowers, in your testimony, you discussed several recommendations for addressing supply chain challenges, and I appreciate those recommendations. What I'm asking is that what lessons can we apply to further pandemic preparedness efforts, and are there steps that we as a nation can take to ensure that we have critical medical supplies that are available domestically rather than enacting the Defense Production Act to get those supplies produced here?
Yes, in addition to the recommendations that you mentioned, we do need to go back and look at our domestic supply chain as a nation in terms of how we can make it more robust, because what the pandemic illustrated is that when it started, we had an inadequate supply of supplies on hand, and the supply chain is made up of a number of players and a number of entities, and so we need to have a better understanding what everyone has and what their capabilities are. And including in that is the strategic national stockpile, and understanding what's the role that's going to play and how we were going to stock that stockpile and how we're going to manage it. Those are important policy decisions for the Congress to consider. And you also mentioned in terms of the supply chain that also we often think about PPE right now, but it's the drugs too. Most of our generic drugs are manufactured overseas, particularly in China and India, and that creates a vulnerability for us as a nation as well.
Thank you so much. Both drugs, PPE, and pharmaceuticals and strategic national stockpile. Thank you so much. I yield back my time, Mr. Chair.
Thank you very much. Gentlelady yields back. Chair recognizes gentleman from California, Mr. Swalwell, for 5 minutes.
Thank you, Chairman. Thank you to the panelists. Many of us gathered last evening on the Capitol steps, House members and senators. We remembered the 500,000 COVID victims that we've lost, and as sad as it was to do that, a lingering thought I had was, will we be back here shortly to remember 1 million lost? And I think what we do as leaders on this committee and with our neighbors and people in the community will determine that. And I want to turn to Dr. Watson and ask you a question, Dr. Watson, about misinformation, because what we learn and how we act on that certainly will dictate future loss. And we've seen harmless misinformation like mouthwash can stop COVID, and we've seen harmful misinformation like ingesting bleach or disinfectants can stop COVID. And we've seen reports of people showing up at emergency rooms because they have done this. So what can we do to combat what is called infodemic, and how deadly is infodemic to our ability to take this on?
Thank you for that question. We have seen that misinformation, I think, on balance, has had a very significant impact on public health and in the pandemic. As you mentioned, from people taking treatments that are unsupported by science to not believing in the virus itself, up until the point of death in some cases. So I think this is a large factor in shaping how the pandemic evolved in this country. The WHO has proposed a research and policy agenda for combating misinformation, which really includes a combination of limiting its prevalence online and improving the reach of high quality information that is health protective, but more research is needed into how we can effectively manage this. I also think that the US needs a plan to combat mis and disinformation, especially as it relates to health.
Thank you, Dr. Watson. Also on the topic of communication, the National Biodefense Strategy lays out the importance of coordination between the federal and state and local governments while responding to a pandemic like COVID-19. Last year, governors reported that they had limited information from the federal government about when vaccines would become available, and they only would learn a week ahead of time as to the number of vaccines they'd receive, leaving many states scrambling to implement distribution strategies. President Biden has sought to increase coordination and communication with the states, especially to get the vaccine and numbers up earlier than just a week out. So what other steps can the federal government do to coordinate with state and local governments? And I'll open this one up to any panelist.
This is from the Illinois response. We can say that we have really enjoyed in the last month communication, and if there is such a thing as over communication from the COVID response team with this new administration. We are very grateful for the 3-week lead time in terms of allocations, which allows for appropriate planning at the state level, and of course for our local partners who can determine the numbers of vaccine appointments that can be made based on knowing 3-week allocations. We are really grateful to hear their priorities and then their plans for supporting us in implementing those national strategies and priorities. So we are really grateful for ongoing communication, and we see that as an important measure to getting on the other side of pandemic. We've also seen responsiveness to issues from the boots on the ground. So as we share concerns, those are taken back, acted on, and then brought back, and collaborative decisions are made.
Great. Thank you to the panelists. Thank you to the chairman, and I yield back.
Thank you very much. Gentleman yields back. Chair recognizes the gentleman from Kansas, Mr. LaTurner, for 5 minutes.
Thank you, Mr. Chairman, and thank you to Ranking Member Katko and to all the panelists. Mr. McMahon, in your written testimony, you addressed Syracuse University's opening in August, and you talk about testing. As we know, the science tells us that college-age students are more susceptible to the coronavirus. They will spread it more easily than elementary students will. So talk a little bit about that process.
Yeah, and so essentially, the testing before the student actually comes into the community was done. Then when they got literally physically on campus, we tested them again. And then Syracuse University has done a tremendous job implementing what is now weekly testing. They've actually even invested into their own lab on campus so that they can meet the state restrictions related to positivity rates now. Before, they were being held to a 2-week period of time where, to remain in-person learning, they could only have 100 cases on a campus of 15,000 students. It's a pretty tough threshold. So testing has been the key to our success in Central New York related to our positivity rate. And it's allowed us to rebalance the public health decisions we're making related to whether it's in-person learning for our pre-K through 12 or certainly our higher ed as well.
And just to be clear, This is months before a vaccine that Syracuse was able to open. Tell me this, you mentioned testing, did they have to spend millions of dollars upgrading ventilation systems or reconstructing spaces to accommodate social distancing?
They did. They spent money, obviously, on the testing infrastructure, right? That's a business decision the university makes to get their students back on campus. Certainly, they did look at updating and investing in ventilation systems, distancing, mask wearing. They were very strict related to, as we all know, the college experience brings different social aspects to it, and we would have hiccups where you would have parties that would lead to cases. The university responded quickly, but because of that and the management of that, to your point, before the vaccine was ready, and again, at this point, students aren't even eligible to get the vaccine in this process now. We've had the spring semester has started, and things are going quite well. The positive rate, if they were their own state at Syracuse University's campus, they would be the best state in the country with the positive rate that they have.
Thank you very much. Thank you, Mr. Chairman. I yield back my time.
Thank you very much. Gentleman yields back. Chair recognizes the gentlelady from Nevada, Ms. Titus, for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding this hearing. You know, we've heard a lot from some members across the aisle about the folks who are at the border, the immigrants at the border, but we haven't really heard much discussion about the 11 million undocumented people who are already in this country. So I'd like to ask the panel, and maybe starting with Dr. Ezeki, how the policies of the former president, including the public charge rule, have affected the undocumented community in terms of getting the virus, getting good information, getting the vaccine, getting good information, and dealing with the virus. You know, that so many are distrustful of government. They are fearful of being deported. They're worried that it'll harm their chances of gaining permanent status. So if you all could discuss how it's been a problem, how we can address it, how it makes it more difficult to deal with the broader community if you have a large segment, like in my district, of folks who aren't vaccinated or aren't willing to kind of put themselves out there to get the information or get the shot in the arm.
Thank you for that question. So as I started in my opening remarks, we understand that no one is safe if everyone isn't safe. And when we have individuals living in our communities who have the virus doesn't care what color your passport is. It will spread to any individuals around. And so understanding that everyone needs to be tested, needs to be vaccinated, is the only way that the whole community will be able to move forward. We have heard on virtual town halls and community meetings that there is a hesitancy to come forward for fear of being reported, for fear of having information being turned over. And so we just understand that all of these individuals who form the fabric of our communities, who care for children, who work in essential roles that are often engaging with the public in high numbers, they will go on to infect other people if the infections and the infection transmission is not contained by either aggressive testing and or vaccination. So again, we just have to understand the basics of infectious disease spread, that we have to control the spread by testing, contact tracing, and vaccination. And we have to take care of all of the people in our midst to get beyond to the other side of the pandemic.
Anybody else want to address that? Well, what you say, Doctor, is certainly true in my district, because a lot of these folks work back of the house in gaming, back of the house in restaurants. They are in service positions where they could be spreading the virus. Also, we have the problem of multi-status families. In one family, one person's a citizen, one person's a dreamer, one person's on TPS, one person doesn't even know what they are, and so if one person is afraid to come forward, then you've got a whole family that will be affected. Well, I think we need to figure out how to do a better job of getting information, not just into minority communities, but into these undocumented communities to try to reassure people and get the best health and science information to them to make them realize this is something in their own interest and not something that's going to come back to bite them like public charge.
Yes, ma'am. We have been trying to message directly in the native language in Spanish, making documents available in Spanish, and working with community-based organizations that already have a leg in those communities to make sure that they have trusted messengers telling them that it is okay, that there is no charge, and that they should take advantage of testing and vaccination.
Well, thank you. Thank you, Mr. Chairman. I yield back.
Thank you very much. Young lady yields back. Chair recognizes the gentleman from New Jersey, Mr. Van Drew, for 5 minutes.
Thank you, Chairman Thompson and Ranking Member Kako. The coronavirus pandemic has had a devastating impact on our nation, with over 27 million confirmed cases and 500,000 deaths in the United States alone. This is a tragedy. In addition to the high death toll, our economy has suffered due to oppressive lockdowns, which have exacerbated the hardship experienced by so many people. States and cities across our nation have seen record unemployment numbers. Atlantic City, New Jersey, one of the most populous cities in my district, had the nation's highest unemployment rate, 34%, last summer. Not allowing people to safely and responsibly resume work is not the answer. Restaurants, gyms, and other essential businesses and industries have been decimated by the coronavirus. My district's economy heavily relies on summer tourism, and those summer months are what drive the regional's economic success. But because of restrictive lockdowns, many businesses had to permanently close their doors, forcing thousands of people out of work. Fortunately, there is light at the end of the tunnel. Thanks to the previous administration's steadfast initiatives like Operation Warp Speed, we now have multiple vaccines that are being distributed and administered every minute of the day. We must continue to focus on how we can safely reopen businesses and our schools and continue to get America vaccinated. America needs to get moving again, and I look forward to that with my colleagues on the committee on how we can best facilitate moving forward again. I have a couple questions for Nicole Clowers. What changes to regulations pertaining to the strategic national stockpile should be changed to ensure that we are better prepared for future disease outbreaks?
Well, one of the things that, first, thank you for the question. One of the things we've called for is, as the administration continues to re-examine the supply chain, which is an effort that's ongoing, that they include the strategic national stockpile, because there's what the pandemic has demonstrated is there's not a good understanding of the role that it plays in terms of should it be the sort of frontline defense, or is it more of a backstop? And what type of supply should be in it? Should it be for high probability but low consequence, or the reverse? These are the discussions that need to happen, and what we've encouraged is for the administration to reach out to the Congress as well as non-federal stakeholders to have this conversation, to make those decisions, because it affects multiple players in all levels of the government.
All right, thank you. And for Crystal Watson, how do we ensure that the data collection is consistent from state to state?
I think that the best way to ensure that is to provide consistent federal guidance to states about how and what data they should be collecting, and then giving them support to do that data collection.
Are we working in that direction?
I believe that CDC is working in that direction, yes.
Okay. So your sense is that we are improving in that area from what you know and understand of it?
Yes, sir.
Okay, thank you. Mr. Chairman, I yield back.
Gentleman yields back. Chair recognizes the young lady from New Jersey also, Ms. Watson Coleman.
Thank you, Mr. Chairman. Thank you for this this briefing to each of those who've participated here. I've got a quick question for Ms. Clowers. It's my understanding that the Biden administration is trying to track down this so-called 20 million doses of vaccine that were released by the Trump administration. However, no one knows where it is or who received it. Do you have any information on this?
We are looking at these issues as well. We have ongoing work looking at vaccine distribution. What we're finding is there's been miscommunication about the number of doses that were available and delivered and allocated. It's an issue that the administration is working on now to try to improve the data. Certainly, we've heard from the national governors as well about concerns about the reporting of the data and the doses that are coming to them, as well as the number of shots that are being given. And so I think it's a communication issue as well as a data issue, but we have ongoing work and are looking at that, and we'll be happy to
Thank
brief
you.
you when we have our report.
Appreciate that. And with all due respect, I think that there's an honesty, lack of transparency, and competence issue that was at play in this former administration. And had we had more honesty, transparency, recognition, respect of the science, as well as competence, we wouldn't have to have this briefing today at this level. This question is for Dr. Ezeki and Dr. Watson. Although there's a big focus on vaccines these days, it's important to remember what other mitigation measures like wearing a mask are proven to work. Over the past year, instead of setting an example for the country by wearing a mask, President Trump downplayed the virus and even mocked wearing masks for months. In fact, Trump berated Biden for wearing a mask, and even after contracting the virus himself, hosted campaign events which were subsequently considered super spreaders. Dr. Ezeki and Dr. Watson, do you believe having our elected officials act as leaders and promote science-based mitigation measures is important in fighting this COVID-19? And if this were done since the beginning of the knowledge of the pandemic, would we not have saved more lives?
Thank you for that question. We have seen that the example of our leaders carries significant clout. We have individuals that decide to vaccinate or not based on people that they trust getting vaccinated. And likewise, we had people turn against masking because there was a culture of anti-masking or that masking wasn't necessary. So absolutely, that's important.
Thank you. Dr. Zicki, did you experience any problems with constituents in your state thinking that it would be safe to ingest bleach and other chemicals as a way of preventing the virus? And if so, to what extent was that an issue for you?
Yes, ma'am. We did have several reports to our Poison Control Center of individuals that were asking about the dangers associated with ingesting bleach after that announcement.
Thank you. Dr. Watson, do you have anything to add to this?
I agree with my colleague, Dr. Ezeki. I think there is no substitute for effective leadership in this type of a crisis. And so I think it's critically important.
Do you agree that had we had that leadership and response in a timely manner when we first encountered the knowledge of this virus, that we would not have the severe loss of life and infectious rate that we have in this country?
I think that improved leadership and better communication would definitely have saved lives. And I think people have died unnecessarily in this pandemic, certainly.
Thank you to all three of you. Mr. Chairman, I yield back.
Thank you very much. Gentlelady yields back. Chair recognizes the gentleman from Michigan, Mr. Meyer, for 5 minutes.
Thank you, Chairman Thompson and Ranking Member Katko, and to our guests who are here today. I want to circle back to a topic that both my colleagues, Representative Marionette Miller-Meeks and Representative Slotkin, mentioned around PPE and specifically domestic production and how that factors into not only the strategic national stockpile, also state level stockpiles. And I guess I first want to start with Dr. Ezeki. Can you, I guess, from your vantage point and your experience at the Illinois Department of Public Health, thinking not just in the moment we're in right now, but now that we have a little bit more light at the end of the tunnel and we have the Johnson & Johnson emergency use authorization out, what can the federal government do to best provide states with the resources, with the guidance necessary so that those state level stockpiles can not only be built back, but also adequately maintained so we don't experience the out of date or expired material issues that we saw on both state level stockpiles and the strategic national stockpile?
Yes, thank you for that question. So I think it might be helpful just to establish national benchmarks in terms of levels that would be considered adequate. We had to dispense PPE not only to our 97 different local health departments, but also first responders and also long-term care facilities. I mean, the needs and the requests came from every direction. And so being able to have established benchmarks and protocols in terms of numbers and levels of storage, being able to have backup at the strategic national stockpile, being able to have plans in terms of when those products would be able to be reviewed, that with ongoing frequency, we would be able to determine whether things that had reached their expiration date could still be tested and still be determined to be effective for use versus needing to be removed. That kind of organization might be very helpful for, unfortunately, the next pandemic.
And Doctor, just kind of building on that, I know the analogy in a home, especially if you might be approaching or just from a disaster preparedness standpoint, is every product in your home has a shelf life, right? And so you get a little bit more than you need, put the newest in the back, take the oldest from the front. Do you think it's feasible to have a similar sort of paradigm at the state stockpile level, where it's not just we have a mass purchase and we leave it there to sit, and then after a certain point it expires, we have to throw it out and buy more, but have more of an evolving stockpile where hospitals aren't just relying on that sort of just-in-time delivery, but there is that kind of deeper bench of material as well?
No, eventually that would be the goal that we would get to. But as we think about replenishing all our stock now, everything that we would get now would all have the same expiration date. So you'd have to go through multiple evolutions before you would have that graduated expiration time.
Thank you, Doctor. And I guess quickly for Ms. Clowers, I know, and again, I just wanted to second Representative Slotkin's desire to have to really hit home on this issue of making sure that either onshoring or frankly, an issue that I want to kind of get your thoughts on, the issue around some of the domestic manufacturers who have spun up their production capability since the start of the pandemic. Some existing manufacturers like 3M, but others in Prestige and Meritech, but other kind of smaller entities have also spun up to meet that, but are having issues accessing frankly, markets for their products, even while we do have PPE shortages because of legacy supply chain dynamics of either large hospital systems or state-based purchasing efforts. Can you share a little bit more on how we can, frankly, keep some of those domestic manufacturers that have risen to the challenge to meet this need in the pandemic, how we can make sure that we not only are finding markets for them today, but also retaining that domestic capability around PPE manufacturing, so we're not experiencing the supply chain risks and the shortages that we saw at the beginning of the pandemic.
Absolutely, and this is an area that we have ongoing work looking at the medical supply chain, and I'd be happy to, as we get further along in the work, to brief you in terms of what we're finding. But you're hitting on the key issues. It's both incentivizing the companies to do the necessary research and development for the medical countermeasures, for example, but then also helping them find those markets. And I think there's lessons that we can learn from existing programs. BARDA within HHS has a program that's designed to do this. It has not been utilized as much as it maybe will be going in the future given the current pandemic, but there's other financial incentives the government could bring to bear. And again, we're looking at all those issues, and we'll be happy to brief you when we have that work ready.
Thank you, Ms. Clowers. Mr. Chairman, I yield back.
Thank you very much. Chair recognizes the young lady from Florida, Ms. Dimmons for 5 minutes.
Thank you so much, Mr. Chairman, and thank you so much for your leadership on this very important topic and important committee. My friend and colleague from South Carolina said earlier that I am one that follows the data, and that's a good thing. And what we do know on this committee, every member, is that Black and brown communities have been hardest hit by contracting the virus, by hospitalizations, and by deaths. Black and brown communities have been left behind in testing and now in vaccine distributions. And the statistics that we've quoted several times earlier today, that life expectancy has changed by 1 year, but for African American communities, it's by 3 years. That is the data. To identify and address equity gaps in vaccine distribution, the CDC requires all states to submit demographic data on those who receive vaccines. I'm troubled, though, that today only 23 states are doing it. Only 23 states think the data is important. This is why I have joined the chairman in writing to FEMA to urge FEMA to double down, redouble its efforts to secure such data from the states. Facts in Florida are also troubling, my home state, where 10% of white Floridians have been vaccinated, while 4% of African Americans and 4% of Hispanics have been vaccinated. I ask unanimous consent to submit that letter, Mr. Chairman, dated February 22nd, into the record.
Without objection. So,
we are a nation where we always go where the need is greatest. So I have to ask the question, what is going on now? For a nation who always go where the need is greatest, but we see the data. And so, Dr. Watson, I'd like to start off with you, because we are not doing well going into the areas where the need is greatest. Could you just talk a little bit about President Biden's Health Equity Task Force and how it can help us in this particular area?
I think this is an excellent point. I think, unfortunately, going where the need is greatest sometimes is also the hardest thing to do, because we don't have established connections. We haven't prioritized reaching the most vulnerable populations in the past. And so what we need now is to make that a top priority, to provide states with the resources to do that, to connect with community organizations in populations that we want to reach, and to ensure that we're getting vaccination, we're getting testing, and we're getting access to healthcare in all these vulnerable populations.
So, Dr. Watson, those are some of the lessons learned as we come out of this public health pandemic and prepare, unfortunately, for the next one. Those are some of the vulnerabilities that we as a response, a nation that responds, suffer from. Is that what you were basically saying?
Certainly, there are underlying factors that have been present long before COVID-19 that we need to address more systemically. But in this response specifically, it will also take concerted effort to reach the people who we want to be vaccinated.
So when we know better, because we like to say this, then we are supposed to do better. That's what we say. Ms. Clowers, in cases where states have not adequately made vaccinations available in Black and brown communities, what are FEMA's thoughts in making trusted venues like churches, community centers, and senior centers designated sites?
That's exactly what the different agencies are working on right now, Representative. CDC, FEMA, and others looking at putting sites in places where people have better access to, that are more familiar, but also places of trust, as you mentioned. And it's not only the location of those facilities, but it's also the messengers, enlisting the community leaders that people trust, and having them help educate everyone about the importance of the vaccine, for example.
Okay, thank you so very much. And you say that's what they're currently working on. How would you assess those efforts? Because people are dying, as we well know, every day.
I would say it's very early. And unfortunately, it goes back to what Dr. Watson was saying. We're building off historic health disparities in this country, and disparities and systematic biases that have been built into the system over years, and what the pandemic is revealing those to us. And so we need to undo those as we go forward, and hopefully not only with this pandemic, but in the future moving beyond.
And part of our job as elected officials is to address those systematic biases. Thank you very much, Mr. Chairman. I yield back.
Thank you very much. Young lady yields back. Chair recognizes the other young lady from Florida, Ms. Carmack, for 5 minutes.
Well, thank you, Mr. Chairman, and thank you to Ranking Member Katko. Also, thank you to our witnesses for appearing before the committee today. There is absolutely no question that COVID highlighted the vulnerabilities in the U.S. domestic supply chain that have plagued us for decades, from PPE to our domestic food supply. The U.S. relies heavily on China as a large source of components that are critical to our nation's supply chain, that are vital to U.S. operations and national security. And I know that many of my colleagues share the same concerns on both sides of the aisle. It is crucial that we prioritize domestic production of these supplies that are critical to the national security where possible, and we need to diversify our sourcing elsewhere. Now, this question is specifically for Ms. Clowers. We've heard a lot today about supply chain concerns, but I want to dig in a little bit more on the sourcing of raw materials, for example. We saw major supply shortages that proved incredibly challenging in the beginning stages of the pandemic and highlighted our overdependence. But much of the materials required to manufacture critical PPE are produced overseas in loosely or non-regulated environments like China. Materials like polypropylene, which are melted down and sprayed to make the non-woven medical masks, for example. My question to you is, given the regulatory environment that we're facing in this new administration, how would you recommend bringing these critical base materials and raw materials back to the United States, given that this administration has stated that they are going to increase the red tape and regulatory environment?
Regarding the domestic supply chain, as well as looking at how that fits into the global supply chain, you highlighted examples of the raw materials for devices and PPE. I would add that also affects drugs, as well, as much of the active pharmaceutical ingredients that are used for drug manufacturing are overseas. And as I mentioned earlier, a lot of that production occurs in countries like China and India. And so when there's a pandemic or other type of incident that affects the supply chain, it can have an immediate negative effect on the healthcare system, as we saw now. I know that the current administration has announced plans to assess the supply chain and identify gaps and what measures are needed to be taken, and that's something we'll be monitoring, and we'll report on that progress and any challenges that we see in future reporting.
As a follow-up to that, what is the timeline on that?
We have ongoing reporting. We'll be issuing our next report in March, and then we have a specific looking at the supply chain and as it relates to specifically API that will be coming out later this year. And I can get you those exact timeframes, and we're happy to, as that report's coming out, brief you and your staff on it.
I appreciate that. Thank you. My next question is addressing one of my top issues that I have here in Congress, which is access to broadband. One of my major priorities is increasing access and affordability to broadband, specifically in rural and underserved communities. And in a pandemic like we have been facing, access to real-time, reliable information is especially important. So with so many people lacking reliable internet access, especially in these rural and urban communities that are underserved, how can the federal and state government ensure that everyone has knowledge of and access to COVID information and vaccine availability? And I'm opening this up to anyone on the panel who would like to answer this.
Thank you for this important issue. So we have seen that digital divide affects individuals in educational settings. It affects adults who may be trying to get information about COVID. So we have expanded call centers, increased the number of operators so that people have the option to just call. If searching through the internet is not an option, that people can talk to a live person who can assist with getting vaccination. We especially are trying to focus on our over 65 population in Illinois, which is consistent with what's happening across the country. 85% of the deaths for COVID have occurred in individuals over 65. So it is really a priority to make sure that those individuals have access to the vaccine, whether they have access to the internet or not.
I would add as well that the digital divide has been real throughout the pandemic. Broadband is something as a country we have to address immediately, but specifically to vaccine rollout, our seniors are confused by the multiple distribution points. So to date, what we've done locally as well is we've created call centers, we've created waiting lists where seniors can call the call center, and then we're logging in their waiting lists. So that and then we're calling the seniors, not just emailing the seniors when they have appointment times. So you really have to adapt and meet the need, all hands on deck, and with this divide that we have right now.
Excellent. Thank you so much. And with that, I yield back.
Thank you very much. Chair recognizes gentlelady from California, Ms. Barragon, for 5 minutes.
Thank you, Mr. Chairman, for holding this very important hearing. I've heard a lot of discussion about the Biden administration's effort to restore asylum processing at the southwest border. Let me be clear, no one in the MPP program has been positive, and testing is happening aggressively. I was just there, and so just so disturbed to hear some of the commentary and make sure we get accurate information. Now, FEMA recently opened 2 managed vaccination sites in my home state of California, each with the capacity to vaccinate 6,000 people a day. This is an amazingly great development, but more FEMA sites need to be added, especially in districts like mine, where I have a district that's almost 90% Latino African American, the 4th poorest in California, and has been hit especially hard during this pandemic. Dr. Ezike, what are the benefits of having the federal government run vaccine centers to augment state capabilities?
Thank you for that question. So, of course, this pandemic has stretched every public health department well beyond their natural abilities. So in addition to vaccination, of course, there's testing, there's contact tracing, there's genomic sequencing. Of course, on top of the normal work of public health, looking out for lead, STIs, tuberculosis. So being able to have that federal support in terms of FEMA with these very productive, high throughput sites, that allows us to shift energy on harder to reach populations that may not be able to get to the vaccination sites sponsored by FEMA, but need mobile teams that the health department can focus on getting those very hard to reach communities as well. So we just need that coordinated large scale effort to make sure that all of this important work gets done.
Great, thank you. Ms. Clowers and Dr. Watson, as I said earlier, I support FEMA aggressively making vaccination efforts. It's important that the location selection prioritize availability to those at greatest risk. This includes underserved communities and communities of color, low-income communities, communities very much like my very district that have been hit very hard. Due to these
I think we lost your connection, Congresswoman. Can you hear me?
as FEMA considers supporting sites.
I'm sorry, Representative, I missed the question.
Sure.
We had some technical difficulties. I'll yield back to the lady an additional minute to get her questions through.
Great. Dr. Watson, back to FEMA aggressive. I support FEMA aggressively helping vaccination efforts, including serving underserved communities. What are your thoughts on how vaccine equity can be addressed as FEMA considers supporting sites?
So I think that's a very good question. Obviously, making these vaccination sites accessible by communities of color in particular, but also other underserved communities. And then also working directly with health departments who know their communities very well to understand how to do some more micro-targeting of communities to help them understand about vaccination, to get them appointments for vaccination and get them access. So it's a combination of these large sites, which FEMA is well placed to help with, but then also working with established networks through public health and other parts of your state to really understand how to target vaccination more specifically.
Thank you. Ms. Clowers, is there anything you would like to add?
Well, in addition to what my panel member mentioned, I do know that FEMA is also conducting a pilot program with vaccination sites, including in California, where they are going to be using CDC data on using the vulnerability index, as well as other census data to help locate where those sites should be. And I think that's a positive development, and we'll monitor closely how that pilot runs.
Great, thank you. One of the outbreaks in my district, and we've seen, is in the complex ports. It's the ports of Los Angeles and Long Beach. There have been serious COVID-19 outbreaks, and my concern is of a possible shutdown and what the implications can be to national security if something were to happen to the ports and this serious outbreak. But Dr. Watson, given how vital ports are to this country, especially the largest by container volume in my very district, are to the economy, should COVID-19 outbreaks at these facilities be treated as a serious threat to national security?
I think it's really important to maintain our infrastructure. And as you said, ports are very important to our national security. So fortunately, there are public health mitigation measures, including frequent testing and contact tracing and supporting people to stay home when they're sick and if they have to quarantine because of a significant exposure. So all of these measures are things we can do for the broader population, but if they're a little bit more targeted, then we can help prevent these big outbreaks at ports.
Great, thank you. I just want to thank you again, Mr. Chairman, for having this hearing. We know that we have a new administration who's come in, who's taking this seriously, who's put forward the American Rescue Plan and has involved the federal government in being a partner and now getting these FEMA sites up, which are great, and getting mobile units out. And with that, Mr. Chairman, I yield back.
Gentlelady yields back. Chair recognizes gentleman from Texas for 5 minutes, Mr. Pfluger.
Mr. Chair, thank you. Panelists, thank you very much. I appreciate the discussion. Ms. Watson, Dr. Watson, my apologies. The strategy that the president has outlined, are you in agreement with that as being a strategy that can work for our country to halt this pandemic and fight back against it?
I think in broad strokes, yes, I'm in agreement with the current trajectory, yes.
Okay. What areas do you disagree with?
I don't have any specific disagreements off the top of my head, but broadly, I'm in agreement.
Okay. One question I want to ask you when it comes to, there's a couple of executive orders that were issued promoting COVID-19, safety in domestic and international travel, and also in the equitable response and recovery. How do we make those decisions? A lot of my colleagues have previously stated today that their districts are being hit particularly hard in underserved districts and populations who may not have that access. How do we pick and choose who's going to get the vaccines? As I understand it, 60 million have been distributed so far.
So not being in government and part of those conversations, it's hard for me to comment specifically, but I know there are I think it's population-based allocation primarily, but then also risk-based decision-making also occurs.
So, as I understand it, and from your perspective, would you say that we have limited resources at this point in time to cover our whole population in a timely manner at this second?
Yes, I don't think the supply that we have right at this moment meets the demand for vaccine.
So diverting supply away from the areas that need it the most would not be a good plan for us?
I think we need to assess where we need vaccination the most, but we need broad coverage across the country. And there has been considered planning in terms of who should be vaccinated and in what order. And so we need to continually reassess that to ensure that it's going in the way that we want it to.
Do you believe it's going in the way you said in broad strokes you agree with the plan?
Yeah, I think the sequenced rollout of vaccine is reasonable. Obviously, I think we have some underserved populations that are not being reached at this moment, so we need to reassess how we can get vaccine to be more equitably distributed. But I think the general plan is reasonable for the country.
Well, thank you very much. Dr. Ezeki, do you also believe that the limited resources that we have in this country should be applied? I think it's, broad strokes, throughout the country, but also to places that need it the most.
Yes, sir. I believe that we have to get as much vaccine out as quickly as possible, but that plan has to be infused with equity to prevent additional disparity.
What would you say about the rural areas, underserved rural areas?
I think that's an area that needs a particular attention, that there's geographic equity that needs to be considered as well. And we also know that, at least in the state of Illinois, we have rural areas, southern regions of the state that have some of the worst health outcomes. So those are high-risk settings that have higher risk that actually need concerted attention and efforts.
So glad to hear you say that. Ms. Flowers, do you also agree that those rural areas need help, as do urban areas, underserved areas?
Yes, we've documented that in our work as well in terms of rural access and the how access to healthcare facilities and treatment can affect those populations.
Well, very good. And I appreciate y'all's discussion on that. My main concern right now, Mr. Chairman, is the fact that any diversion of any of our resources away from those in this country who need it the most is a tragedy, whether it's rural or urban or underserved or any population in the country that needs to get access to vaccines. My district is incredibly rural, and we have a very difficult time with the access to that. And so when it comes to folks that need it the most, we need to make sure that they're getting that. Specifically, in my case, a rural district. And so I have a very hard time understanding how the president's plan does not take into account a strategy when it comes to international travel, especially overturning immigration policy that would put us further at risk and not get those resources and vaccines to those who actually need it the most, as all of our witnesses have just agreed to. With that, Mr. Chairman, I yield back. Thank you very much.
Thank you very much. Gentleman yields back. Chair recognizes the gentleman from New Jersey, Mr. Gottenheimer, for 5 minutes.
Thank you, Mr. Chairman. COVID-19 has taken an immense toll on the communities I represent in northern New Jersey, where we were hit early, unfortunately, and found ourselves in the eye of the COVID-19 storm. Almost a year later, we're still working hard to get through the pandemic. I recently visited vaccine sites across northern New Jersey, including in Teaneck, at the Rada Community Center run by Holy Name Medical Center, at Bergen's Newbridge Medical Center, at the Sussex County Fairgrounds in the Meadowlands, thanks to our frontline personnel who've done such a great job of setting those up and running them. As you know, many of the vaccine distribution systems are still being set up, and we are working hard to expand vaccine availability. I was very encouraged by the president when he recently announced there will be an increased flow of vaccine doses headed to the states and communities.
I think the gentleman from New Jersey is having some challenges. we will work through those challenges. Mr. Torres, if you're ready, we'll yield to you at this time. Mr. Torres, if you can get on, we'll go to you while we work out the challenges with Mr. Gottenheimer. Well, it must be a New York, New Jersey thing. We'll go to the other gentleman from New York.
Did you call me, Mr. Chair? I'm sorry. Oh, I see Josh.
Sorry, Mr. Chairman, it appears I have an internet problem.
Well, it looks like everybody's having problems. Mr. Garbino, are you available to talk? We're still not able to hear any of our last three members. Must be a systems issue. Well, we're not really sure what it is. Mr. Torres, can you hear me?
I can hear you, Mr. Chair.
Well, if you can hear me, please go ahead with your 5 minutes.
Okay. Thank you, Mr. Chair. It's refreshing to have a new president who's committed to crushing the virus rather than crushing our democracy. When it comes to pandemic response, timing is a matter of life and death. Delay is deadly. The longer the delay, the higher the death toll. If the Trump administration had put in place social distancing restrictions at the beginning of March, it would have cut the death rate by as much as 90%. We as a nation have paid a heavy price in the lives of 500,000 Americans for the lethal incompetence of the Trump administration. My first question is about the way forward. There is no return to normalcy without population immunity. What is the timeline for achieving a population immunity? And are we confident that population immunity can be achieved given the systematic failure to sufficiently vaccinate communities of color? Communities of color like mine are often the first to be hit the hardest and the last to be vaccinated. This question is for the Government Accountability Office.
In terms of when we'll reach societal immunity, I think it's a question to be determined. I've seen some suggest it could be earlier this spring, to some that it'll be much later into the year, and certainly a number of factors would drive that. One is how well we do with the vaccinations over the next several months. Are we able to get the supplies that we need in terms of doses and get them out and into the arms of Americans? That's really going to drive in terms of how quickly maybe we can get back to somewhat normal life. But in terms of, we've also heard the experts talk about that we'll be continuing to need to utilize public health measures such as social distancing and masking for the foreseeable future because of hard to reach communities, and making sure that everyone in the United States is vaccinated to the extent that they can be, but also we live in a global society, and until we are see the containment of the virus across the world, all of us are at risk. And so it will be many months, but it's something that we'll be watching very closely.
Is there a concern that we might fail to achieve population immunity before the emergence of new strains that render the vaccines ineffective? Is that a...
Well, that's certainly it's certainly a concern among the public health community, and my colleagues might want to address that. But it is a race with the vaccination against new variants. Viruses are constantly mutating. A lot of those mutations don't prove effective for them, so they die out. But certainly, as long as there's host in order for them to continue to mutate, that's a problem. That's why we want to get as many people vaccinated as quickly as we can.
I do have a question for Dr. Watson about the future of SARS-CoV-2. some viruses like SARS-CoV-1 and MERS get eradicated, and some viruses like influenza remain endemic. Is COVID likely to remain with us in a post-COVID world? Influenza kills tens of thousands of people every year. Is COVID going to kill tens of thousands of Americans in a post-COVID world?
I'm not a virologist, and I don't even think my colleagues who are virologists know the answer to this yet. But I do think we are seeing increasing information that makes it more likely that SARS-CoV-2 will remain with us, not just in this pandemic, but beyond. And it may be something that we face on an annual basis. And so we need to gather more data and try to understand what that looks like, but then also pay close attention to our vaccination efforts and determine whether we need to update vaccinations over time and people need to be revaccinated. But there's so many unknowns with this right now.
And my final question is, what can be done to bolster the rates of vaccination within communities of color? I just find the rates to be alarmingly low, and it's going to undermine our ability to achieve some semblance of normalcy. So any thoughts on what can be done to bolster vaccination within communities of color?
I can take that. I think there is hope. You are correct that our communities of color have lower acceptance rates of the vaccine. But all the individuals that have said no, maybe who've even been offered the vaccine and said no, they do fall into different buckets. There are individuals that are simply not first, where they weren't ready to get it when it was first offered. They didn't want to be amongst the first individuals to get it. And as other people have gotten it, as the tincture of time has passed, they have come around and have come maybe on a second and third visit and third offering have now taken it. We have some people that were just not sure. And so they still needed to gather more information. They needed to seek reassurance from trusted messengers, whether it's in the faith community or medical providers that are trusted. And then there are some that are, not ever. So, I think the not ever are a smaller group. And so there's still lots of work to be done in terms of community engagement, working with trusted messengers, giving out culturally appropriate messages, virtual town halls, using venues and people that can be trusted to share the message. We've had lots of physicians and medical individuals of color who have been documenting their COVID vaccine journey, and I think that has helped. We have lots of, personalities that have come out to share their COVID journey. I think with time, as people see the safety and the efficacy of this vaccine, you will have more of those individuals come. And so, but we have to continue the engagement.
Congressman, if I could add on that, I think method of distribution matters. And with our success we've had within our minority populations, we've worked with credible messengers, we've worked with churches, we've had pop-up clinics at housing authorities. We've worked into our looking at our library systems in the neighborhoods with pop-up clinic models. We have not had as much participation with our minority and new American communities in the traditional mass vaccination sites, even though one of our mass vaccination sites is in the heart of a neighborhood in our downtown, right next to one of our poorest neighborhoods. So I think method of distribution really matters as well with credible messengers.
Absolutely. Chair recognizes the gentleman from New York, Mr. Garbarino, for 5 minutes.
Thank you, Mr. Chair. Is it working?
Yeah, you working.
Wonderful. All right. Thank you very much. I just have a few questions. Dr. Ziki, you spoke about getting the vaccine out there as much as possible to all different sorts of groups. The Biden administration launched the first phase of the federal retail pharmacy program, allowing pharmacies to distribute vaccine doses. Has this initiative been successful so far in Illinois?
Well, I think as with the entire vaccine rollout with these very complicated vaccines, there has been a steady increase in the throughput, steady increase in the comfort of getting it done. And so I think we have We are very excited that all of our long-term care facilities that were enrolled in the program, and we had over 1,400 facilities that were enrolled, but I think we have had all of our skilled nursing facilities have at least one visit. We expect all of them to be done in the coming weeks, and we've already moved on to our long-term care facilities and other congregate care settings. So, everything has been a learning curve, but we've had great partnership with our CVS and Walgreens partners. We've been working on the phone every week, multiple times a week, to make sure that we iron out kinks. When we hear about long-term care facilities that have a complaint or an issue, we have been able to take that back to make sure that we keep correcting and improving the process as we go along.
But so the pharmacy, so far what you've seen with the pharmacy program, with this, like you said, CVS and the Walgreens, it's been a positive. It's increasing, or is it is increasing the vaccination doses that are being administered? Would you say that?
Yeah, it's helping us get more vaccinations in arms. So we're grateful for the partnership. We need many different partners for this effort.
Great, I appreciate that. Thank you. And I just want to move on. Ms. Clowers, hopefully I got that right. There's two questions I had. One, you talked about in your testimony, you mentioned that HHS, the data on COVID-19 in nursing homes is incomplete because they didn't require in the first 4 months of the pandemic to report data. Has there been any? And I apologize if this has been asked, but has HHS done anything to go back and get that data, or anything to try to recapture that data so we have a full picture?
They have not, and we continue to believe that's a really important step for them to take. As you may know, that until May of last year, nursing homes did not have to report cases and deaths to CMS, and in May, CMS put out information to them and said, you're going to start at this point reporting that information to us going forward. But they didn't have the nursing homes go back to the beginning of the pandemic and report that information. And we think it's really important that that information is captured because that is information that could help us better understand the spread, especially during that period, through that vulnerable population. And I can give you a quick example of how this data affects and the types of data that we're missing. As you might remember, it was about this time last year, one of the first sites of spread was in the Kirkland nursing home in Washington. And if you look at the HHS data, it will show during the, that there were 0 cases and 0 deaths in the beginning months of the pandemic for that site. Well, of course, that we know there was over 100 cases and unfortunately about 23 deaths in that nursing home. And so that's just one example of a piece of data that's missing, and we think all that data needs to be collected. And we think it can be done in a fairly a non-burdensome way for nursing homes to report that information so we have better insight in terms of what was going on during that time period.
That's great. That was my next question, whether or not we could get enough good data that it would actually make a difference. So that's great, and I agree with you. I think we should get that. As you know, my state of New York, we've had this has been in the news quite a bunch lately. It's something I dealt with when I was in the assembly last year on the health committee. So I think it's very important we get that information. And just another question, a lot of strategy documents have been issued in the last several years that may encompass a portion of the COVID response. In 2005, HHS developed a pandemic influenza plan, and the Biden administration just recently released the National Strategy for COVID-19 Response and Pandemic Preparedness. Are there anything in these plans that these strategic plans are missing? Is there something that are in these plans, in your opinion, that are not in these plans but should be?
In terms of the past plans that we've reviewed, we did find elements were missing. Everything from very clearly stating what the risks are, what our goals were, what would be a benchmarks for success, consistent definitions, as well as the resources that are needed. The new administration has put out the response plan. We're currently evaluating that, and we're also waiting for additional plans that are to be forthcoming that were required by Congress, the additional testing strategy that should be coming out at the end of March, and we'll review that to make sure that it contains all the information that's necessary for an effective strategy. And I'll note then it's really important that these strategies are publicly available so that everyone understands their roles and responsibilities.
I appreciate that. Look forward to hearing more about it. Thank you. And last, Mr. McMahon, I just wanted to say my friend Bill Barclay.
Gentleman's time
hello.
has expired. Gentleman's time has expired. Chair is going to recognize again the gentleman from New Jersey, Mr. Gottheimer.
Thank you, Mr. Chairman. Is this better?
Much better.
Sorry about that. As I was saying last time, COVID-19 has taken an immense toll on northern New Jersey, where I represent. We got hit early and very hard and found ourselves in the eye of the COVID-19 storm. Almost a year later, we're still working hard to get through the pandemic. I've recently visited vaccine sites across my district in northern New Jersey, in Teaneck, and a center run by Holy Name Medical Center, at Bergen Newbridge Medical Center, at the Sussex County Fairgrounds, and at the Meadowlands to thank our frontline personnel for helping distribute the vaccines. As you know, many of the vaccine distribution systems are still being set up, and we're working hard to expand availability. I was deeply encouraged when the president recently announced that there will be an increased flow of vaccine doses headed to states and communities like ours. The administration also announced plans to buy 100 million additional doses of the Moderna and Pfizer vaccines, and the Food and Drug Administration today endorsed the emergency authorization request from J&J, a great New Jersey company, for their new COVID vaccine, with final authorization hopefully coming later this week. We need to keep up the pressure until we can fully deploy vaccines across the country to help us safely reopen. Dr. Watson, how can we help accelerate the production deployment of vaccines, and what sort of role can FEMA play in that effort?
I think the government is working really hard to accelerate the production, and I don't have any specific comments on that, although I think there are lessons that we can learn for the next pandemic there in improving production capacity in the U.S. But in terms of rollout, I think FEMA is an excellent partner, as was discussed briefly earlier, in setting up vaccination sites and helping states coordinate vaccination efforts. As long as it's being coordinated with the health department, I think that can be a great asset. And so it's one thing I think we need to look back at our previous plans and maybe reassess in the future what is FEMA's role in these types of public health emergencies, because I think they haven't formally been engaged in our plans to the extent that we have realized they've been needed in this response. So I think that's a good thing for our after action reviews.
Thanks, Doctor. Do you agree we should deploy these pop-up vaccine sites in every congressional district, including in rural areas, to make sure we reach those underserved populations?
Yeah, I think as my colleague said, every connection, every partner in this effort for vaccination is probably appreciated.
Thank you so much. I appreciate that. Mr. McCann, as a county executive, you have experienced firsthand the immense challenges faced by our local counties, towns, and municipalities during COVID-19 pandemic. Across Jersey, our communities have been hit hard, some of them facing unfortunate tasks of having to lay off essential and frontline workers or making painful budget cuts to essential programs and services. Can you discuss how this is a bipartisan issue for states like New York and New Jersey, and what the grim outlook is for our communities if we in Congress fail to provide robust aid to our state and local governments as part of our next relief package?
Yeah, I really do see this as a bipartisan issue. And essentially in New York, what was unique with our situation is we didn't receive direct aid in the CARES Act, like many communities under 500,000 in their population. And because of that, we had to make mid-year budget cuts in 2020. We had to incorporate those cuts into 2021. For my community, we're a $1.3 billion budget. In 2021, we made $84 million worth of cuts. We had retirement incentives, we had furloughs, we had layoffs. We want to bring back some of these people. I have people in my adult and long-term care department doing contact tracing, my social services doing contact tracing. And there's other elements of the pandemic. I referenced earlier that the human services side of this pandemic is going to be glaring next year and later in 2021 when we're done vaccinating. So the aid is important if we want to shore up our efforts. And when you look at recovery efforts, we're large employers, we're large spenders. We buy capital, we pave roads. All these budgets got cut drastically in 2020 and 21.
Thank you so much. I yield back, Mr. Chairman. And thanks again for coming back to me despite the technological issues here.
Thank you very much. Well, given the level of member participation in this hearing, obviously there has been great interest and impact, more importantly, in their respective areas. Let me thank the witnesses for their testimony and the members for their questions. The members of the committee may have additional questions for the witnesses, and we ask that you respond expeditiously in writing to those questions. I don't want to overemphasize rural underserved communities. I have 26 counties in my district. 13 of those counties, we don't have a Walmart, we don't have a Walgreens, and we don't have a CVS. But we have churches, we have schools that have buildings and other things. So I'm working trying to get people to go beyond just what the printed paper requires in order to get people vaccinated. So I really thank our witnesses for helping the committee. I mean, you've gotten us to a good point where we can work with this administration on overcoming this pandemic. Collectively, we can do this, and your testimony adds immensely to getting us there. Without objection, the committee record shall be kept open for 10 days. Hearing no further business, the committee stands adjourned. Thank you.